We started Let's Talk Menopause because we knew, and I knew from my own experience and our co-founders' experience, that women were not getting the health care they needed. They were not getting the information they needed. 75 million women are in perimenopause, menopause, or postmenopause, and 80% of GYNs are not trained. We're not getting the health care that we need and deserve. Okay? So we started Let's Talk Menopause. Our mission is to make sure that women are empowered to get the information they need and the health care that they deserve. I want to thank a few people really quickly. We want to thank Cure for this amazing event space. I want to thank Samara Daly, who's the board chair and who has made all of this happen with me. So thank you, Samara. Right there. Jessica Levin, who does our menopause talks and did all of the amazing content here today, which you will see. She's incredible. Stacy Geller, who is our designer. I mean, really, she does all of our social media content, our website. She's back over there. She is fabulous. Sandrine, who is our event coordinator, fantastic. Dara Freed, who's an advisor to Let's Talk Menopause. Judy Sage and Christopher Gillespie, who from Red Heifer Media, who helped us with our PR. And of course, special thanks to our sponsors, Always Discreet and Astellas, who helped us do this today to get all of you together, and all of our partners who made this happen. We really appreciate everything that you've done. I also want to just thank our board of advisors, and of course, our amazing doctors and panelists who are absolutely fantastic. I have just so I didn't do that. Let's Talk Menopause. That's our partners. There we go. Our medical disclaimer. So just really quickly, this is not intended for your own personal medical advice. Okay. Always see a menopause-informed practitioner about your own experience. Okay. And when you do ask questions, please, we know we want to get to everyone's questions, but please try to be as general as possible. We're not going to be able to answer specific questions about your own healthcare, but if you ask a general question, that would be great. And the Q&A is open, so you can ask those questions now at any time. Also, we ask that you not videotape. You can take photos, but please don't videotape, okay? The agenda. So we have 3 panels. Our first panel is on perimenopause. It's an overview. Our second panel is on mental health. And our third panel is on GSM, which you'll learn all about, but it's basically all the sexual, vaginal, and urinary symptoms in menopause. So we picked these symptoms specifically because they're the least talked about symptoms. So now we are on to panel 1, and I'm going to hand it over to Tamsen, but I just want to say that Tamsen Fadal is a dear friend to Let's Talk Menopause. She was here began with us at our inception. She's an award-winning journalist turned menopause expert from her own experience, and she courageously shared that experience and has now brought so many women into the fold and wants to continue to do this work and bring it into the workplace and develop workplace policy. And that is really her #1 mission and goal. And we are so thankful to have her here. Just you wait and see. And just you wait and see these incredible panels that we brought together. So I'm going to get off the stage now and let them go. Okay? Thank you.
Thank you. How's everyone doing this morning? What do you guys want to talk about? A little menopause, a little perimenopause to get the morning started, right? What's better than that to start a Friday? So, you know what, I'm so encouraged to see everybody here. I love when everyone kind of comes to life off of Instagram and social media. So thank you, first of all, and give yourselves a hand for being here, because I feel like this is a way to acknowledge what is going on and to educate ourselves as women. And that's what we need to be doing, so we can educate girls that are coming up behind us, and our daughters and our nieces and our sisters. And, you know, that's what this is all about. And we have 2 incredible doctors here with me today that I want to introduce. And I'm excited, as Donna said, for you to ask your own questions as well, because listen, as much as I feel like I read and try to educate, I learn something new every single day. And that's certainly what we're going to do here today. So let's get started. Dr. Mary Jane Minkin is a highly respected practitioner, a Yale professor for over 42 years, and a leader in women's health education, especially on menopause. And I have interviewed her several times. And she cracks me up and makes me feel like it's okay with all of these symptoms that I go through, and everything that I think is so abnormal, she says is perfectly normal. Dr. Robin Noble is an Let's Talk Menopause board member and chief medical advisor, Yale and Columbia trained gynecologist in Maine with a specialty in menopause. So, you know, we want to thank you both for being here, first of all. I appreciate your time. I know you talk about it a lot, and I know you get a ton of questions. So we're going to see what we get from the audience and from people that are joining us virtually, actually, as well. But let's start off, in Robin, let's start with you. Can you start by defining menopause and perimenopause? Because for me anyway, I work in journalism. I never said the word menopause on television. I had no idea perimenopause existed until 2 years ago. Can you define those two terms?
Sure, and I think you're absolutely right. It really contributes to the confusion, and I think when we change these terminologies, it sometimes doesn't help patients. So I think we can still be kind of inclusive in general. I still use perimenopause a fair amount because it really encompasses the the time before your final menstrual period and the year after. But we've moved to in the, academic societies calling it the menopause transition, the early and late phase. The early one being characterized by some of the changes in cycles that can vary from, heavier bleeding, changes in hormonal symptoms, increased PMS symptoms, to that later stage where you can even see 2 months between cycles. Then we have that final menstrual period, which of course you don't know till 12 months have elapsed, which makes it incredibly confusing, and we're not good at predicting this. So that's why I feel the terms aren't as important. Perimenopause kind of including the time around it.
Okay, and so let's talk about that. Mary Jane, is there a test for perimenopause?
I wish there were, and the term
Me too.
that would be wonderful. And the person who invents that becomes a billionaire, not a millionaire. The problem is that the term, that a lot of changes can occur before any blood changes are noticed, okay? And perimenopause really is a retrospective diagnosis. So Robin and I both, and all the docs here, nurse practitioners, we've taken care of patients who will get these symptoms and will be going prospectively and saying, gee, I don't know, maybe they may be fairly young, because that's the other thing. Remember, menopause can occur as early as 35 or as late as 60. And that's all normal. I mean, there's nothing that's abnormal about any of that. And so if somebody's getting some funky symptoms in their late 30s, early 40s, well, is this perimenopause, or are there some bad social things going on, or do you have thyroid disease? There are a lot of things that can mimic these quote-unquote perimenopausal symptoms. And I wish there were an exact test that would tell us, oh, you're perimenopausal, but it's truly a retrospective diagnosis. And what I find with my patients, who I love to be able to follow forever, and will say, remember that thing you were having back about 6 years ago? Well, you know what? Now that you haven't had a period for a year, I know that was perimenopause. Great. Did a lot of good for her back then.
I'm with you. There's so many symptoms too of perimenopause, menopause, the menopause transition. A lot, we know about. We know the hot flashes. We know the brain fog. We know that there can be weight gain. We know irregular bleeding. There are some lesser known symptoms, things that we don't know. And then that's when we start to worry. What do I have? What's wrong with me? Is this normal? What are some of those lesser symptoms?
Yeah, and that's such an important point, because I think it's so confusing for so many people, doctors as well. As we mentioned, a lot of people aren't well educated about it, but people can worry about cardiovascular symptoms, get symptoms like panic attack, exacerbation of anxiety, heart racing. That can lead them to a cardiologist. They can have more bloating, abdominal pain that can lead them to GI. And I see a lot of orthopedic issues, in the 40s and perimenopausally, joint pain, frozen shoulder, more and more tendonitis. There are estrogen receptors in all these tissues, so it can impact, the brain, the gut, the joints. And all of these things can really wreak havoc and make it confusing and scary for people.
I had, a lot of you know this because I've told the story before, but I was on the news set anchoring the news at 10:30 at night, and I got what started to be, it seemed a hot flash, didn't know what it was, but my heart was racing out of control, and I couldn't breathe, and I couldn't think anymore. I was seeing words, but I didn't know what they were. And I think that that's when it really becomes scary, is that you do not know what's going on, and then that panic ensues. And at the time, I was one of the women that was still bleeding because I had endometrium polyps, so going 12 months without a period wasn't the case. So that's where it really can become confusing for women.
Yeah, and one of the other, and Tamsen brings up an interesting question, because sometimes as as a gynecologist, nurse practitioners, whatever, we are trying to rule out pathology, and when somebody's getting funky bleeding is part of the issue. So oftentimes there's the issue, well, is there some pathology going on, or is this just funky hormones leading to crazy periods? And sometimes, I know my patients sometimes get mad at me when I want to get an ultrasound or do an endometrial biopsy or something like that. And I'll say, but I just want to make sure there isn't anything bad that we should be dealing with, like surgically, whether this is more hormonal issues. And it's very hard to define sometimes.
So I want to talk about this because we refer a lot to the 2002 study. We refer a lot to the headlines that were scared a lot of women into flushing their estrogen right down the toilet. For people who don't know or understand what the 2002 study was and how it still impacts us today, can you briefly talk about that?
That's you.
I'll let you do it.
You have that perspective.
Get the hook and get me going. All right. Life was good until 2002. No, what happened? The WHI, the Women's Health Initiative study, was a totally legitimate study. I don't want anybody coming out and say, oh, Mary Jane thinks the study was bogus. It was an excellent study designed specifically to ask, does estrogen therapy help prevent heart disease? That was the focus of the study. And where that study came from, it's important to understand, is that there were some studies, and I have some friends here, so I'll make a little joke with it. But anyway, there was a very prominent study that was done at Harvard, and I have to admit it was a good study, even though it was done at Harvard. But anyway, I know I have friends here. So anyway, but the key thing is the nurses study, basically, and they followed 121,000 nurses, female nurses, as they went through life, which included perimenopause and menopause. And what they noticed, and these women were fabulous, they would fill out survey after survey and volunteer their blood and urine and all sorts of fabulous things that could be studied. And what they noticed is that the women who happened to be taking estrogen, who were given estrogen therapy, not as part of a study, but this is an observational trial. They were just watching this. But the women who took estrogen actually had much less heart disease as they followed these women. And this study was really started, we're talking about the 1970s, folks, which is not ancient, but a while back. And these women had a lot less heart disease. Well, what didn't they have in the 1970s, things like that, were statins, for example, for the heart. So really was nothing known for women's health at that point about how do we help prevent heart disease. Of course, we knew about nutrition and exercise and all that stuff. But what happened is folks started saying, gee, maybe we should start prescribing estrogen, not just for hot flashes or vaginal dryness or things like that, but maybe we should start prescribing estrogen just as a means to lower the risk of heart disease. Ta-da! That's the origin of the WHI. And so what happened is folks started saying, and they did correct in the studies for weight, family history, other medications, other issues, blood pressure problems, but it seemed that these women did better, okay, to a tune of about 50% reduction. It was pretty significant. And so folks started saying, yeah, but maybe the ladies who are taking estrogen are somewhat just intrinsically healthier, the healthy user effect. So they said, we need to do a prospective, randomized, double-blind trial, okay, to see whether estrogen helps prevent heart disease. Logical, totally fine. That's the WHI. A couple of problems with the WHI, though, is they deliberately actually decided, well, it makes sense. If you want to study heart disease, do we prevent heart disease? Who is it better to study? A woman who's 50 or a woman who's 65? Not that 65 is old. It's quite young as far as I'm concerned. But the issue is that, well, they're younger than I am. But anyway, but the key thing is that it makes sense to study older women, they decided. So the average participant that was enrolled in the WHI happened to be about 63 years old. 20% of the women who were enrolled in the WHI were between the ages of 70 and 79. Again, that's very young, but not for studying a use of estrogen. I don't put too many 70-year-olds de novo on estrogen. Okay, so they did this study and a whole bunch of other health issues there. And what they discovered was that, and the other thing, I have to back up, that they also had a stop thing because it had been rumored that maybe estrogen might have something to do with breast issues. So the Data Safety Monitoring Board said, okay, if we start seeing an increased number of cases of breast cancer, we're going to stop the study. Okay, so those are sort of the two things they came to. And what happened is, in the beginning of the 2000s, 2002 particularly, they noticed that, number one, they didn't seem to see a decreased risk of heart disease. So the primary endpoint that they were looking for does not, I'm supposed to, oh, sorry. Wait a minute. So somebody basically, they showed that didn't help prevent heart disease. But the other thing is they saw a very, very slight increased risk of breast cancer in one group. The other thing, I know I'm going on, but I have to make a
I know.
qualification here. There are two groups of the WHI, and we're going to be talking more about this all during the day today. There were ladies who had had a hysterectomy, and there were ladies who had not had a hysterectomy. Why is that relevant? Well, if you have a uterus in place, we unfortunately have to give you not only estrogen, but we have to give you something called progesterone or a synthetic progesterone to protect the lining of your uterus from getting overgrowth, okay, of the lining of the uterus. The ladies who don't have had a hysterectomy, they don't have a uterus, you don't got to worry about that. So they could take estrogen alone. The ladies who had a uterus in place had to take estrogen with progestin. And already by the 70s, we knew that maybe the progestins have an additional, maybe not such a great effect on the lining of the uterus. They have a great effect on the lining of the uterus, but they have some other effects, cardiovascularly and stuff like that. Well, lo and behold, in the beginning of the 2000s, they found in one group, the ladies who had a uterus, estrogen plus progestin, there was this very, very slight increased risk of breast cancer, and that there was no significant drop in heart disease. So the study, quote unquote, failed, and they decided we're going to stop the study at that point.
And that's where your headlines come in. And that's
where the headlines come in.
And that's where a lot of women come to you, both, I'm sure, and say, doesn't hormone therapy cause breast cancer? And that's where that fear comes from.
Absolutely.
So much to say about that. I mean, even in the sense that, sadly, many people will get breast cancer. It's really common in the US.
Sure.
And even if they happen to be on hormones, it doesn't mean that the hormones cause the breast cancer. But there's so much confusion in the general public and sadly amongst a lot of physicians about the connection. The connection, as Mary Jane points out, was actually very, very small.
Mm-hmm.
And just to give you some numbers, I think numbers help. And I like to talk about absolute risk. There are things called relative risk. There are things called absolute risk. And basically, first of all, these changes were noted after 5.5 years of therapy. So it's not like you take 2 estrogen tablets, you're going to get breast cancer. I promise you it would be unrelated at that point. And I actually write that on papers for my patients. So anyway, so the key thing is that what were the numbers? Well, as Robin pointed out exactly, that unfortunately, breast cancer is a common disease. It's horrible, but it's common. And the incidence of breast cancer in basically the control group, ladies who weren't taking any estrogen at all, basically was about 30 cases per 10,000 women per year diagnosis of breast cancer. In the group of women taking the estrogen plus progestin for over 5 years, the incidence was about 38 per 10,000 women per year, okay? So the fancy term for this is called the attributable risk. And as I always say, since I'm married to a mathematician, I can do this high-level calculation. 38 minus 30 is 8, okay? Tell my husband. Anyway, so the key thing is that the attributable risk to the estrogen plus progestin in this data set was 8 per 10,000 women per year. Now, but the key thing is that, as both Robin and Tamsen have pointed out, that breast cancer generates such fear, understandably, in American women, that I have patients who will say, oh, that's such a high number, I can't possibly think about it. I'm not going to ever give that woman any estrogen and progestin. I don't want that woman to panic every time she swallows a pill. However, if somebody says, you're telling me I have to put up with symptom X, symptom Y, symptom Z, for an incidence of 8 per 10,000 women per year, you're crazy. Give me the estrogen and progestin. Of course I do. So that's sort of the way I look at the numbers.
And I think what's important to also say is that, let's talk about hormone therapy, because there's other things besides just saying, okay, it's not going to, I won't have hot flash anymore. Maybe my brain fog will go away. Hormone therapy, what is it? And there are some really real things that it can help with.
Yeah. So, I really focus on individualizing the treatment to the person and what their background risk of some of these things are, but really what their goals are and what their individual symptoms are. So hormone therapy can actually help almost all of these things. The hot flashes, certainly the sleep issues. If the mood's intimately related to that, yes. If the joint pain, usually we see that. Certainly, as we'll get to later, vaginal symptoms, urinary symptoms. So really that's what improves. I remind my patients, anything that happened right around this time is likely hormonally mediated, those specific symptoms. And those things are usually what we see rolled back. The thing I want to point out, though, is so often this happens in a woman's life when there's so many other variables.
Yep.
When they're smacked between caring for maybe aging parents and young children, and they might have other career transitions, stressors, financial stressors. Throw a pandemic on top of all of that, and it can be confusing, right? What's what? but they usually really do help with those symptoms.
So there can be some confusion between hormone therapy, hormone replacement therapy, and now menopause hormone therapy.
Something
So
that
what are
said.
we calling it now? Just so we're referring to it the right way and we know what it is.
I'm old, so I use old terminology. So anyway, I must confess the older term is hormone replacement therapy or menopausal hormone therapy. The key thing is, and this is a political correct issue, and I am probably the least politically correct person in the room, so I apologize. But the issue on the replacement is, yes, menopause is a natural phenomenon. Our ovaries poop out. Now, I'm not saying it's great that they do, but it does happen to all of us, God willing, we live long enough. So the key thing is that some of the more politically correct people will say, oh, replacement means we're supposed to have hormones forever, and nature says we don't. So that's the issue of replacement. So the correct term, by the way, is hormone therapy. I apologize in advance because I still say hormone replacement therapy a lot. So anyway, okay, that's the issue.
No, that's good. I think it's important to know. Okay, let's talk about safety. How long can you be on hormone therapy, and what do we need to know about progesterone as part of that process?
So again, I fall back on individualizing therapy. I mean, there are general guidelines about when it's, kind of more reasonable to start hormone therapy. And I think we should address that so people have a general idea.
Okay.
Which really, the sooner around that transition, the safer it's thought to be. So there are general guidelines that women within 10 years of this are still candidates. Frankly, I think you still need to use shared decision-making and informed consent. And I occasionally have someone that finds me that's struggling 10 years or 11 years out. And as long as she understands that, that's not a no-go. Similarly to that duration, as Mary Jane pointed out, after 5 to 7 years with combination therapy, we have to acknowledge that there might be this increased risk in breast cancer, but that doesn't mean someone has to stop and discontinue.
Okay.
I have some patients in their 70s, 80s, 90s that are on combination hormone replacement therapy, but they have to understand that we need to accept some increased risks.
Sure. Okay. Sorry, these have become a new accessory. I want to make sure that the slides. So there are two kinds, local and systemic. Can you explain the difference just briefly with those two?
Sure. Basically, local therapy, you're going to be hearing a terrific panel talking about vaginal therapy. That local therapy tends to imply that we're using it vaginally, okay, or on the labia and the vulva and things like that. Whereas systemic therapy basically is a medication that's going to go into the bloodstream and get to every part of your body. Okay, now we have two major ways of giving the systemic therapy. We have pills, which basically go in the mouth, and I demonstrate my body to people. I even show my patients my ovaries, which haven't done a damn thing in almost 20 years. But anyway, but I said, this is where the ovaries are. So basically, you swallow the pill, it goes in the esophagus, it gets to the liver, okay, which is something we'll talk about, and then gets into the bloodstream. There's also transdermal methods, patches, gels, things like that, which you place on the body, different places, and they get absorbed into the bloodstream. Now, folks say, but it gets to the liver. Everything gets to the liver, but it gets to the liver in a dilute form, so it doesn't give a blast to the liver. So there are some differences in metabolic issues. Okay. There is also one ring, which makes it a confusing thing, so I have to get that out of the way. There is one ring that is good for local therapy and one ring that controls them all. No, one ring that, good joke. But basically, there is one ring that delivers just vaginal therapy, and there is one ring that delivers systemic therapy. Important thing to remember about local therapy, the systemic absorption is minuscule, okay? I will not get up here and say zero, okay, because it's not zero, but it's very, very, very small. And the North American Menopause Society and the American College of OBGYNs have written official position statements based on data that says that even women who have breast cancer, not worried about getting breast cancer, but actually have the diagnosis of breast cancer, may safely take vaginal estrogen therapy because of the minuscule systemic absorption. Now, I have to qualify that. There are oncologists in the world who will not let my patients take will not let my patients use vaginal therapy. We can have a long discussion about that. But there is literature out there to say, and also they do recommend trying local therapy, which is non-hormonal first, but if you fail that, you can take
so let's talk about that, because there are a lot of women that either cannot take it or do not want to take it. So what are some of the non-hormonal treatments first?
For some of the systemic symptoms, more hot flashes. So there's some antidepressant medications or SSRIs, selective serotonin reuptake inhibitors, that are actually, one of those is FDA approved for hot flashes and Paxil. That's, I believe, the only non-hormonal one. And there's some, central neurologic, gabapentin is something that we can sometimes use. Some of the other SSRIs. What else do you find, Mary Jane?
Well, those are the mainstay of the medical therapies that we have currently. There are a couple others that I personally haven't had a lot of luck with. There is a blood pressure medication called clonidine that some people use. And if you want to pass out, that's fine. But anyway, I don't use it a lot. I am a prejudiced person. What can I say? I share with you my concerns. There are a couple of herbal preparations which I think do help. The North America, I have to be fair and balanced. Me and Fox News, anyway, whatever. But that the North American Menopause Society really does not endorse any herbal therapies. I think there are some herbal therapies that can be quite helpful. Unfortunately, I mean, it's good that we live in the United States, but unfortunately, our herbal products are not super well supervised here. So I tend to go with more European products, German products, Swedish products, where they basically police their herbal products a lot more carefully. So I do recommend certain products there. And
what are those products for supplementation?
The ones that I've had good luck with, there's a German product called Remifemin, which is a black cohosh product, and it also has a product line extension called Remifemin Goodnight, and which helps with sleep. And this is the most widely used herbal product in German breast cancer centers. And I basically run a breast cancer center, so I use it a fair amount. There's a product called Relazin, which is a Swedish pollen extract, which is well recognized and stuff like that. There are also some soy products, which I think we should mention, that basically Equel is one of them, which is a soy derivative. Again, there's some controversies. We can spend several hours talking about that. Is soy good or soy bad, breast effects, etc. I think it's fine. So we use that. And there's one other promising product, though, coming out now, which is, so those are the herbal mainstays. But there's a product that I think you all ought to know about, and this is sort of stay tuned because I can't prescribe it for you now, but it's at the FDA and hopefully will be approved at some point in the near future. It's a very new concept in hot flashes. And it basically is a medication that works. And the other thing that I use is a line, and you're free to use this with your significant others or whatever. When somebody says to you, yeah, it's all in your head. Yeah, it is all in your head. Right here, it's the hypothalamus right behind this area. And the temperature regulatory center is right here, pituitary hypothalamus. And there is a new approach basically to some, and the neurons that are involved in there, and you're all going to get excited when I say this, are called candy receptors. It's not that kind of candy. It's kisspeptin, neurokinin, and dynorphin, but it's close enough. And there is a very interesting chemical called neurokinin, which seems to be involved in this. And there's a new class of drugs which are called neurokinin receptor antagonists. Some of you have been reading stuff about this, and they are actually probably pretty close to fruition. You cannot get them yet, but stay tuned. Probably within the year, we are anticipating they will be available. And the nice thing that I am looking forward to is, unfortunately, as Robin said, there are SSRIs, there's gabapentin. Unfortunately, for many people, these have a lot of side effects, which can be bothersome. Now, some people are great. Some people are fabulous. They get no side effects, and they get great hot flash relief, and that's terrific. But unfortunately, the side effects can be problematic. So it looks like with this new class of medications that are coming out, that the side effects are going to be a lot less.
Are we talking about in the next year?
I think within the next year.
Okay.
I think within the
That's
next
encouraging.
And I think that's, really at the root of hot flashes. We think there's a thermoregulatory zone and that it narrows during this time. And we don't even understand a lot of why that happens. But this is really getting to the aspect of that thermoregulatory zone. That's why some of the lifestyle modifications, which some people can have a lot of luck with, certain diets, a green Mediterranean diet, exercise can be helpful. Everybody's probably heard dressing in layers. But we think that when we get a little bit out of that temperature regulatory zone, that's what might stimulate a hot flash. So when people drink a hot cup of coffee or they walk up a set of stairs and they get a little flustered and a little hot, if they can take off that sweater and maybe stay in that narrow zone, not that that's what we always want to do, but that's probably the root of why some of those hot flashes happen. So it's really exciting to have some new options.
Estrogen probably helps, as Robin says, widen that thermoregulatory zone, and these neurokinin antagonists will also seem to help us do similar to what the estrogen does.
All right, so I want to talk about
she can-
doctors, and doctors in particular, gynecologists that aren't always educated, like both of you are, in terms of being able to talk about this. And a lot of times people feel very discouraged. They feel not heard. They feel like they don't know who to go to get some help. There are a lot of doctors that don't have menopause training in medical school. Is that right? I mean, we're talking a very shocking number of hours, if any hours.
We're talking, most of them don't get training.
And it's partially because of the WHI.
Yeah.
Now, why is that? Well, and we have 20 seconds.
We
Okay.
don't have several.
Basically, all right. So what was happening in 2002 is we were trying to shorten residency training hours because you didn't want your residents up all night, and we were beating up on our poor
That was
residents.
after I was finished, right?
That's correct. She got trained good. She got trained
I'm
good.
in the old
The
school,
best,
all
the
the
best.
hours.
So anyway, so she's good. So she's terrific. But anyway, so they tried to cut the residency hours, and they have. And the other thing that was nice and convenient is when this WHI came out, people said, well, we're not going to be using this estrogen stuff anyway. None of these patients are going to want to take it.
Right.
So why bother teaching menopause? Why? It's a waste time. So anyway, so it was a good, because you have to teach a resident how to deliver a baby. You have to teach a resident how to do a hysterectomy. You got to teach those things. Well, maybe you won't teach them how to give hormones. Okay, we're done. So anyway, and that's what happened basically. So we have, and so I don't blame the kids coming through, my youngins here, but we really basically didn't focus a lot of time on menopause education.
Well, and so where can people go to find doctors that are trained in this area so they can feel comfortable?
So I think, one of the best resources is probably looking on the NAMS website for
Yeah.
a certified provider that tells you that not only are they just a member, but they've actually done additional training and clearly demonstrated as an interest. But it varies so much because some people can be taken care of by a primary care provider that's really well versed in this.
Sure.
And some of the OBGYNs really aren't well versed or comfortable talking about even some of our next panels like sexual function and libido. So you almost have to suss out whether you feel they're well trained, they're open to it, and you might get to some of those red flags of like what to be worried about or maybe suspicious about. But it is a real challenge, and this is partly why Let's Talk Menopause is so important, to spread the word,
Yeah.
empower women, get people to really demand better care and know where to go.
And by the way, so you're saying NAMS, and then for those of you who might not know, it's North American Menopause Society, and there's also a place on the Let's Talk Menopause website as well under the resources tab. So you can go there, and it's really simple. You put your zip code in and see if there's a provider in your area.
And the NAMS website is menopause.org.
Yes,
So
thank
just
you.
plug in
Thank you.
menopause.org and you'll find menopause people near you. And the other thing that I do have to stick in here is that we have many, many people who are NAMS members, and you don't have to be a NAMS member, but who are not MDs. We have some fabulous nurse practitioners, nurse midwives, PAs. So, and the other thing is, with the current state of American medical care, which we can spend many days talking about, that the average office visit is about 20 seconds sometimes.
Yeah.
And that many times you'll find.
Not with you.
Not with me. You can't shut me up. That's the problem. But anyway, but the problem is that sometimes the nurse practitioner, PA, nurse midwife will have more time to spend and talk about these issues.
But
Absolutely.
so that brings me, and thank you, because that brings me to some tips on how to prepare for a doctor's appointment and those red flags. Because I think nowadays you can't just cruise in and feel like you're going to get all the answers. I think you have to really come armed with some information.
And this is one thing I might interject too, because of these pressures on all these visits. Very often people are scheduled for a regular annual preventative visit. And if they have a list of all of these things going on, it's really not easy to do that well. So I do think setting the expectations that this really deserves its own visit. And I know, Donna and our LTM people, we're really looking at advocacy and trying to get better coverage for menopausal care because it deserves the time. It really needs the time to do it well. And that's one of the struggles is if a physician's trying to screen you for, breast cancer, cervical cancer, make sure you're exercising and eating well, and then you have a whole litany of symptoms that really deserve that time. We're really stuck between that.
And let's real quick go over the potential red flags. If you were in an appointment, and then if you all have questions, we're gonna hit those in about a minute. But talk about the potential red flags if you are going into a doctor's office and one or two of these things are happening, what you should know about.
I mean, I always worry if they say, that they're never going to prescribe hormones, they're unsafe, they're clearly not informed. if they really don't evaluate some of those symptoms that can be concerning, like abnormal bleeding, they really should be thinking about the other possibilities if they're trying to sell you anything. And a big red flag, unfortunately, we're seeing a lot of marketing around menopause and femtech, is that if they're trying to sell you anything, because really we should be able to do this inexpensively. A hormone therapy does not need to be expensive. It shouldn't be customized. We can talk more about, compounding. Sometimes compounding is necessary when there isn't an available product or there's an allergy, but there are FDA regulated hormones that are safer, less expensive, available, and we really do direct people to use kind of things that are rigorously tested, and and we know better about, we know how they're absorbed better, the safety.
And one of the other issues that I'll just expand further, because Robin wants me to say this. Anyway, that I've known her for a long time. One of my star residents. Anyway, that compounding pharmacies, and of course, I'm also going to blame everything on WHI. Compounding pharmacies really came into fruition, whatever, in 2002. And why did that happen? Okay, is that when you get a product at your pharmacy, it comes with a package insert, which tells you basically you're going to die no matter what it is. Even if it's derivative of water, you're going to die if you take it. So the key thing is compounding pharmacies don't have to have a package insert in there. Okay. So when my patient comes in, well, the stuff from the pharmacy, the compounding pharmacy is safer. I said, yeah, because they didn't put the package insert in. You don't have to. And so basically the compounding pharmacies are much less regulated. And if they give you estrogen, estrogen's estrogen, and it's going to have the same risks whether you take it from a compounding pharmacy or from a regular pharmacy. So it's intrinsically safer. And indeed, there's so many potential hazards in it. So in general, the North American Menopause Society really strongly discourages the use of compounding pharmacies, except for certain situations. If you're allergic to a certain component in the standard product, well, you get it in a particular hypoallergenic form. Compounding pharmacies are terrific that way, but not for general hormonal use, as Robin said.
I'm so glad you mentioned that, because I think there are a lot of questions about that. Okay, let's see. I think our questions are going to pop up on the screen. Is that right, Donna? Okay. All right. I think we're ready for questions. And we can, let's see.
We can have people
We can
stand
take
up
a
too.
couple.
Yeah, why don't we just take them on here? If you guys have questions, if you want to just raise your hand or stand up, and all right, right here. Hi, how are you? What's your name? Valerie. Hi, Valerie.
There was talk about this natural hormone. Talk more about that.
You do that one.
Well, everything is synthesized, okay? And we have to work in a laboratory to make just about everything. However, the key question is when people talk about natural products or bioidentical, whatever, I think that's the term that the compounding folks use a lot. Basically, and again, I'm at fault. My ovaries, which haven't done anything for 20 years, basically the hormone that your ovaries make is something called 17-beta estradiol. Okay, that is the bioidentical hormone. So there really isn't a medical term bioidentical. We just adapt it to say that's what your ovaries make. Your ovaries also, when we ovulate, we make a hormone called progesterone. Okay, so that's the natural product. And so when somebody says bioidentical, to me what that means is something that contains 17-beta estradiol and progesterone. Okay, that's identical. Now, there are many, many compounds which are much easier to make or have some different attributes, which are estrogens, okay, but which are not bioidentical. They're fine, okay? They work well, they're fine. They may be cheaper to manufacture, things like that, perhaps. So they're fine. And we also have a lot of synthetic progestins. The reason we use progesterone or progestins is to basically keep the lining of the uterus from overgrowing. There are many compounds which can do that, okay, which act as progestins, but may not be exactly the same as what our ovaries make. So that's the basic difference there.
Yeah, that's a great question, by the way. Okay, so we've got some questions coming in. I want to get to them. The first one, my career is suffering because of all my menopause symptoms. I'm not myself. I don't know if HRT is safe for me. Where do I start? I'm 53 years old.
So I see patients like this every day, and it is so pervasive, and The other challenging thing is it's because this process is so variable, people can have their best friends who are blissfully unaware and have no symptoms. So people can feel really alone. They can lose some confidence. They can have these brain fog symptoms. I really like to impart to my patients that most of these things are really treatable. We have choices. I'm a big believer in trials. I mean, I tell my patients, you're the expert. You know how you feel now? If we try something, you're going to be the expert. And the goal is to make things better and not make things worse. So with somebody like this, I would say absolutely, if you want to try something, we should get you on hormones, and you're going to be the one who can really assess what those risks and benefits are. And I also reassure them that you're not signing on to 10 or 20 years of this. We're going to do a trial. We might have to adjust things a little bit, and we talk about it yearly, and if anything comes up, we might change tactics, but it doesn't have to be scary to even start a trial for 2 to 3 months and see how you feel.
Yeah, I mean, Mary Jane knows, actually, I talked to you about this several months ago, that I've had a little bit of trial and error with my situation. And so, but overall, it feels like I can at least function at work now. Okay, why do some doctors order hormone level tests if menopause can't be determined by a test? When is it useful?
Occasionally, okay. I presume you wanted me to shout out.
Yeah,
one of my favorite
you can
topics here.
alternate.
Exactly. So the key thing about doing a hormone test, unfortunately, many patients love hormone tests. Okay, and we live in America. Some people hate hormone tests or blood tests. Some people love blood tests. And if I have a patient, for example, who comes to me who's 53 years old, like our friend before, and she hasn't had a period in 2 years, and she's having hot flashes and night sweats, and she's miserable, and she wants me to check her hormone levels. Please check my hormone levels. I'm like, why? They cost a lot of money. Go buy a dress with this money. It's not going to help me. I know what's going on.
That's
now,
the doctor you want, right?
Yeah, I buy a dress. It's nice, or pants. I don't care, whatever, obviously. So the key thing is that certain times hormone levels really don't tell you a damn thing because we know the answer in advance. Now, if I have that 53-year-old woman and I've put her on estrogen, okay, and she's not getting better as I think she probably should, yeah, you bet your bippy I'm going to order a hormone level, because some people are chewers up. They metabolize like crazy, and she needs a higher amount of estrogen. She may not be absorbing it well. I mean, all the things that I need to know. So in her, I'm going to order a hormone level because it's going to guide my therapy and help get her a better dosage. Okay. Now, if I have somebody who's 35, let's invert those numbers. Okay. Who's 35, she hasn't had a period in 2 years, 2 months. She hasn't had a period in 2 months. She's having some hot flashes. I probably will order a set of thyroid functions first. And I also a blood pregnancy test to make sure she's not pregnant, because that's the #1 answer for my medical students when I quiz them on this. But the key thing is that once I've ruled out pregnancy and thyroid disease, I am going to order a set of hormones, because that's really important. If it doesn't tell me anything, okay, and I will tell her this may not give me the answer, but if I find you have funky hormones, I want to get cracking on this, because you're a real young person and I got to work on this. So their hormone level I will draw. But the problem is, and I just got one more second on this, is the hormones during the normal menstrual cycle vary so much that if I get a hormone level on you, I don't know whether it's normal, okay? Because the blood levels, let me give you the numbers. The blood levels at the lowest part of the menstrual cycle in a Jane Doe average menstrual cycle is about 40 picograms per mil. At the highest part of the hormone of your menstrual cycle, you probably have a blood level of 300 or 350 picograms per mil. So if I get a level of 50 on you, is that normal? I don't know.
Yeah. And just to add to that, I mean, this is, especially in that menopausal transition, it's really can be a roller coaster of very chaotic hormones. So that speaks to why they're not helpful. But there are situations where we can genuinely be confused. When someone has a Mirena IUD and they have no idea about their bleeding pattern, it can be helpful there. If I have someone that's 53 and they're blissfully unaware and we're not sure, sometimes that can be confirmatory. But I agree, most of the time they're not helpful. They're a waste of money. I worry about having direct to, patient marketing. But there are times where we can be a little bit confused and we need to kind of confirm or understand things a bit better.
And I bet you we have a couple of women in this room who've had a hysterectomy. I think that's a fair guess. If people have had a hyst, we don't have a bleeding pattern to judge stuff on. So sometimes people are getting peculiar symptoms. So sometimes a hormone level there can be very helpful.
Yeah, great.
All right. Another question. I had an endometrium ablation and have not had a period.
Yeah.
Oh, Wait, what?
No, it's
It's
the
the
same
same
kind of
situation. It's like
Oh,
the
I thought I was
Mirena
misreading it.
IUD or
Okay.
hysterectomy.
So
if
we
they
already
can't
answered that
tell-
question?
Yeah, but one important thing here, I have seen that with an endometrial ablation, the goal is
Yeah.
to just ablate that lining. Occasionally, it can impact the blood flow to the ovaries. So
Yeah.
I've seen some people go into an early menopause after that.
Okay.
So it is really important if these symptoms start to get some hormone testing.
I think I saw a hand go back there. Oh, okay, hi. Okay, go ahead.
Consider, like we as women really for so much discomfort and pain and suffering and fuck up and not say anything, and just deal with it. So at what point, how bad do your symptoms have to be to explore this when you're in perimenopause and having brain fog and getting hot flashes, not sleeping and so on and so forth?
I don't want anybody
Before
to be
that.
miserable.
Yeah,
before
that.
then, please.
I mean, there
please.
really shouldn't
No
be a
bucking
judgment
up,
about how
right?
bad
Yeah.
it is, or even that speaks to how bad are the hot flashes. It really should be, what are your symptoms? What do you want? How do you
Exactly.
feel about it? I encourage my patients to think philosophically. Do they just want to see what happens naturally, or do they want to step in? But the message I give is so many of these things are treatable. So if you want to see how things go, more power to you. If you feel like I don't want that, it's impacting my life and my work, we can step in.
Do you know what I think though? I really like your question because I think it speaks to something much bigger, is that we think that we have to be miserable and we have to suffer for a long time before we can get some help. Like, when am I worth getting help? And, and that's not the case.
Yesterday.
Yesterday.
Last month, 6 months ago, whenever you want to come
Yep.
see us.
Okay, is it true you have to wait a full year after our last period to start hormones? Can you start taking hormones during perimenopause?
Absolutely.
Okay, can
Same
you
thing.
expand upon that a little bit?
Yeah, and one of the best ways to manage a chaotic perimenopause is actually with birth control pills, because they have a slightly higher level of hormone that suppresses all of this chaos, and people can just be blissfully unaware and be managed on birth control pills really through kind of an arbitrary time frame where we then stop them and see what they're doing. And this can be confusing for people, because I occasionally have a patient come in who's on birth control pills. Her hormone level is going to be exactly the same, and she's convinced that her weight gain, her sleep issues, her mood issues are all menopause related. And I have to have that uncomfortable conversation and say, unfortunately, they're not, because your hormones are exactly the same. But that can be a great way to manage perimenopause. You do not need to be suffering. Perimenopause is a time where PMS symptoms can really become exacerbated.
Sure.
Breast tenderness, bloating. People can just say, as long as there's not a reason they can't use it, like a breast cancer, they can elect to treat that.
Stop smoking.
Stop smoking.
Okay, so this is a question. I think, Mary Jane, you kind of answered this one, but because you said that estrogen and different things are processed in the body differently. I want to know more about hormone replacement therapy. I'm on medication for hot flashes, but they still don't work well. I'm assuming the medication is
Like Paxil or an SSRI.
MHT. I'm not sure.
I'm on medication for hot flashes. Yeah. I mean, I think the question is what are the medications that you're taking that basically, and there are no head-to-head comparisons that I can cite for you to say that this is X% effective and stuff like that.
Sure.
As a clinician who's taken care of a few menopausal ladies, basically and I'm Robin, I could ask your opinion. I bet you're fairly close on this. I would say that the SSRIs probably are about half as effective as hormone replacement therapy as far as symptomatology. Similarly, gabapentin. So it's going to give you some relief. Unfortunately, it's not going to give you perfect relief. So indeed that we can probably do better for you if you're okay taking hormone therapy. One of the reasons, again, I'm looking forward to fezolinetant is I think it is going to be a much more effective method to take care of hot flashes and the current things we do have to offer people, which are non-hormonal.
Okay, we have a few more questions. We have just about 7 minutes. If you have just had your uterus out, you experience menopause symptoms. What about if my ovaries are also removed?
So in these cases, surgical menopause is often more abrupt for people and more, bothersome and acute. After a hysterectomy, there are more health benefits to estrogen therapy than there are risks. And it actually, nobody hears this, but decreases our risk of breast cancer, colon cancer, and osteoporosis. And bone health is something we really need to be aware of. So pretty much uniformly after hysterectomy, somebody should be treated with hormones.
If they're now, I think if I'm misreading this, though, somebody may shout out. I think one of your questions is, what if you leave the ovaries in place and don't take the ovaries out, but have a hysterectomy? A couple of issues there. Actually, transiently, like a week or two after your hysterectomy, there may be some deviations in your blood flow in your pelvis, and you may experience full menopausal symptoms, hot flashes, night sweats. So there are often many people that even if I leave their ovaries in, they'll call me up and they're like crazed with hot flashes. I will put them on estrogen for a couple of months and see what happens as their ovaries sort of take over with new blood flow. The other thing to remember is although the average age at menopause in the United States is 51 and change, having a hysterectomy decreases your age at menopause by 1 to 2 years. So the average age is probably 49 to 50 as opposed to 51. And if you want to go through menopause early, folks, I guess you've figured out, we're not brought to you by RJ Reynolds here, that I am not a big fan of smoking. So if somebody wants to ruin your ovaries early, start smoking. You will go through menopause on the average of 1 to 2 years earlier.
And
So
tubal surgery, like there are other things where it can happen a little bit sooner.
Do we have any other questions in the room before? Yes.
Because of breast cancer or chemotherapy. I know the symptoms are worse, but can you just describe the difference between like the drop in estrogen immediately versus over time and how that affects people who have that situation?
basically, chemo is more of a gradual thing. It's not like overnight. It's quick, but it's not as overnight. The surgical menopause is in general the quickest and toughest to go through, because basically you can start dealing with symptoms. We won't, I say we put patches on in the recovery room, but sometimes we do. But as far as if somebody's ovaries come out, so that can be really sudden as far as that precipitous drop. The other thing that is also relevant is that if you're somebody who's 30 having your ovaries taken out versus somebody who's 50, again, not that 50 is old, but our hormones are gradually decreasing over the course of time. So somebody who's 30 who has her ovaries out is really, in general, unfortunately, going to have very significant symptoms, probably even more so than somebody who's 50. Don't get me started on that. Aromatase inhibitors are not kind to your estrogen levels. So unfortunately, people can be very symptomatic, and we do have lots of tricks that we can try with those folks.
Yeah. All right. Rachel.
I'm going to come out from behind the pole. This is a room where we're preaching to the choir, and this is like a summer camp for people who want to know about menopause. And we have experts here answering questions, but you said something earlier. There are a lot of issues in feminine health on the business side. What can we do to actually change what up-and-coming physicians and residents are being educated with? I mean, you made it, the numbers are startling. Menopause isn't getting smaller. There aren't fewer women. The trends continue, and we want to have a whole new generation for our daughters, and if I live that long, granddaughters and grandsons, grandchildren. That was a separate, the grandsons was just personal. I know they don't go through menopause. What can we do to change the course of our new doctors, our next generation being prepared?
I think, events like this and anything that increases awareness is really helpful. I think people are demanding better care. I think this isn't the best way to do it, but it is happening, that this is percolating out. And physicians, even in my own organization that aren't OBGYNs, are reaching out to me. I feel like I don't know enough. I need to educate myself. So it's happening. It's not perfect. And I think, that speaks to, unfortunately, what's happening in the marketplace too. For good or bad, we have disruptors and people doing direct to patient marketing because we're not doing it well in medicine, but we will catch up, and people just have to spread the word and do events like this and
advocate for yourself too.
Absolutely. And at a federal level, we're really trying to work at policy.
One other thing to remember, and this is what I try to lobby with everybody, as you can well imagine, that what's happened, there's also patient pressure, okay? And the key thing is that what happened in 2002, women who were perimenopausal all threw their estrogen in the toilet that night, trust me. And nobody was using estrogen. What's happening now, and I see this a lot, is that younger women are making a difference, because women who are now in their 40s are coming to see their provider, and they're saying, I feel like crap, okay? And the doctor might say, well, they did not get poisoned by the thought about, oh my goodness, this drug causes breast cancer, okay? Their mothers were poisoned by that thought, but they're like, What are you talking about?
Yeah.
Okay. So I think there is pressure from the younger women
Yeah.
coming up, putting pressure on lobbying for more education. So I think it's a terrific question.
Yeah.
And I think those young women are helping us.
So a point of confusion for me is, in society, we're used to, women are used to bucking up and being strong. And so the person that has hot flashes, it's easy for many women to just kind of blow it off and deal with it. And we know that taking hormone therapy isn't recommended to be proactive as far as reducing cancers and things. But so I feel like for those people that are so like strong, kind of like, I'm an athlete, I'm used to blowing it off type of thing, they're not taking hormone therapy. And then are they actually not being fair to themselves? You get what I'm saying? I feel like that's a point of confusion where if you're strong enough and it doesn't bother you and you can live life happily, then don't take hormone therapy. But in
You're
fact,
saying as a last resort, do that.
like, why wait for it to be a last resort when in fact there are benefits?
Right.
And that's what I really talk to my patients about, and I kind of push them even in their mid 40s to start thinking about this philosophically. What does this mean to them? What do they want? How do they want to age? I mean, we know their impacts on bone health. There's starting to be, a body of literature that says women really should be offered this until age 60, that for most women, there are probably more health benefits. So I think, again, the conversation is changing and needs to change, because even those patients that don't really have terrible hot flashes, there are benefits to bone health that are really important. And the mortality of a hip fracture is about 20% in that first year. We're very, very good at treating breast cancer, thank goodness, and the risk of dying from breast cancer is really low. So I think the conversation really needs to change about cardiovascular health, bone health, breast cancer, and where it fits in for that individual person. And really, they should be empowered to do what they want to do. And I think all of us, we need to judge less, right? And I think if we're kinder to ourselves and allow people to make the decision that's right for them, that would help all of us.
Okay.
Go that direction.
Well, hormone therapy is recommended for the prevention of osteoporosis. It still is, and people don't hear that a lot. So if someone doesn't have hot flashes and they're at risk for bone density issues, it is FDA indicated for the prevention of osteoporosis.
All right. So we have another panel coming up, and I cheated the time a little bit, but the questions are so good. First of all, thank you both so much. I just, to be able to ask you questions and feel normal and feel heard is so important. And we appreciate your time and your knowledge and your expertise and just making us feel like it's all going to be okay.
My pleasure.
Yeah.
It will be okay.
Yes. Everybody, if you could take your seats, because I don't want to be late getting started with our next fabulous panel. Why I don't feel like myself. I ask myself this every morning. I know. Hey, everybody, if you could take your seats, because we want to go ahead and get started. Wow. All right. Well, how's everybody doing? How's everyone doing from the last? All right, get your questions ready, because we have an incredible panel. We've got 4 doctors now, and we are going to buzz through these questions that we have so we can get to yours as well. But, we really want to kind of set the stage on stories, talk about hormones and how they impact mental health, because that is so important. Talk about diagnosis and treatment, and then some more Q&A. But we really want to answer the question why we don't feel like ourselves these days, and I think that that's really broad but really important. And that's kind of it at the end, right? Is that what we want? We just want to feel normal, whatever normal is. So let's go ahead and get started. 4 amazing panelists right now, and I'm just going to give you a quick bio of each one. And if you guys want to wave whenever I say your name, Dr. Alexander, a psychotherapist running a private mental health practice in the Dallas area. Dr. Kingsburg, clinical psychologist, professor at Case Western, Division Chief of Behavioral Medicine at University Hospitals, Cleveland Medical Center. Dr. Jeffers, nurse practitioner with a doctorate in nursing and co-director of the Center for Midlife Health and Menopause at NYU Langone Health. and Dr. Weinstock, a New York psychiatrist in private practice with a focus on women and mental health during key reproductive transitions. So let's see, Dr. Alexander, let's start with you. Can you begin by sharing your story?
Yeah, I was forced into menopause at 45 because the fibroid tumors had taken over and I wasn't well informed. The doctor actually told me on the operating table while I was under anesthesia, going into the room, he asked me, he hopped up on the table and he said, "So are we doing a full or a partial hysterectomy?" And I said, I didn't know that there was a choice. And so he said, if I do not take your ovaries today, we may be in the same position about 2 to 3 years from now. And so I said, I don't ever want to go through surgery again. Let's do a full hysterectomy. So I was not informed, did not realize all of the things that came with having a full hysterectomy. And there you go.
And your story is not an uncommon one, because we have heard a
Unfortunately.
lot of women that, I mean, when you're laying there as vulnerable as can be.
Right.
And what's the right answer?
Right. Very anxious at the time. Had actually witnessed my mom going through surgical induced menopause when I was a kid. So I knew I did not want to have a hysterectomy, but at that point, my doctor said I needed to do it.
Well, thank you for sharing your story, because it's one that so many of us can learn from and be aware of, but probably, some people can relate to. Dr. Kingsburg, let's talk about this, the sudden loss of hormones through surgical menopause. And somebody did bring up surgical menopause and chemotherapy a little bit earlier, but let's talk about that, because it is likely, obviously, to impact mood and versus a gradual loss.
Oh, sure. And in the last panel, you heard that loud and clear. If you lose your ovaries and have a sudden loss of hormones that were working just fine, that's going to have a considerable effect on all kinds of things, but in particular your mental health. Having that trauma on the operating table is yet another story. But we now have the question of take it or leave it, is the question that many surgeons have. When do I take those ovaries? And we actually do have guidelines that would say absolutely not at 45. Usually not at 50, maybe at 65, and Mary Jane, Dr. Minkin would say that's too young anyway. But that certainly is way too young, and the circulating hormones that change, everything is in the brain, and hormones absolutely impact neurotransmitters that will impact your mood. So if you are prone to hormone-related mood problems, that's going to happen.
Dr. Weinstock, let's talk about how and why hormones impact mental health. You specialize in reproductive mental health. What is that?
So reproductive mental health, or reproductive psychiatry, is really a subspecialty of psychiatry and mental health in general, because it's not just psychiatrists that work on this, psychologists, social workers, nurse practitioners, where we focus on mental health issues, psychological and psychiatric issues that impact women across the female reproductive life cycle, sort of specifically focusing on areas like PMDD, issues that happen, in the week before a woman gets her period. PMDD used to be called PMS. We focus on women having trouble if they're going through infertility treatment. How does that impact their mood, the hormones that they're taking, and just the basic trauma of infertility. We work with women during pregnancy who either have pre-existing psychiatric issues and they have questions about how to manage them during pregnancies. Are medications safe? What are their options? And women who may develop new problems during pregnancy. We work with women in the postpartum period where you have a very rapid change in your estrogen level, and many women are at risk for developing, if not postpartum blues and postpartum depression, postpartum anxiety, God forbid, postpartum psychosis. And then we work with women in perimenopause and menopause. And in all of these phases of the female reproductive life cycle, we see hormonal fluctuations. And as Dr. Kingsburg said, we know that estrogen and progesterone don't only work on your uterus, and they don't only have a feedback to your hypothalamus to make sure that you go through regular reproductive cycles, but they have impacts on our brain cells in lots of other ways. And so when we have these fluctuations at these different points across the female life cycle, there are certain women who seem to be more vulnerable to developing worsening mood symptoms, whether it's depression or anxiety, new or worsening of what they already have.
So, Dr. Jeffers, I want you to jump into this. How much does the risk of mood problems, how much does it increase during perimenopause into menopause?
Well, I think what all of these issues have in common, and you laid that out so beautifully, is really this window of vulnerability. So anytime there is a hormonal transition, which women have many times during their life, but particularly dramatic at perimenopause, that whole menopause transition is a very spiky time of a lot of estradiol variability. And so this creates a window of vulnerability that's very specific to this time. And what we find is that in early perimenopause, and I think our first panel laid this out so beautifully, in this whole menopause transition, there's early perimenopause and late perimenopause. And in early perimenopause, women, even women who haven't had mood disorders in the past, will be about 1.5 times more likely to develop a mood disorder. And that increases to almost 3 times more likely in the later perimenopause. So that's a really dramatic risk factor. And we know that women who have had mood disorders previously, or women who've had PMS, PMDD, postpartum depression, all of these things, or a history of anxiety and depression at other times in their lives, will certainly have a greater increased risk. So it's a real window of vulnerability.
Okay, and any of you can jump in on this at any time. Here's what I do want to say, and I'm not alone in having heard this story, but when I first started going through symptoms of moodiness, depression, just feeling very not me. The first thing that happened when I went to my doctor, my primary doctor, is I was handed antidepressants. I was handed Lexapro and told to go on 10 milligrams of Lexapro and call me in the morning. And that's what I did for a significant amount of time, and it didn't change anything for me. And I have heard that story over and over and over again. So what does that go back to educating and doctors needing to know more?
It really does, because they're looking for quick solutions. I mean, I think that's our system at this point anyway. And if we don't advocate for ourselves and explain, no, it's not just that, I wasn't struggling with this a year ago, or there's nothing that has significantly changed, they're not going to slow down and listen to us. So part of it is educating ourselves and then educating the clinicians.
Can I jump in? Can I also comment that I really wish they would make women-friendly lavaliers, because our fashion doesn't always work. And so it's not working very well on my jacket.
They can still hear you if it's clipped on you.
Oh,
Yeah,
okay.
yeah,
Well, they were like saying you're.
Oh, they weren't hearing you? Okay.
Yes, they were
All right.
signaling me. So let me just say that in your case, the question is also timing, because you are perimenopausal, hormones might have been a better option for you. Although it is not indicated for depression, it is the teasing out of, are you postmenopausal, at which point hormones will not help with depression, or are you peri and early postmenopausal, at which point it's a fair thing to try, particularly if the SSRI isn't going to work. So it really is a timing issue for that as well.
Well, so let's go to this because this slide shows a lot of different things that women experience. There's signs and symptoms. Changes in mood, though, obviously one of the first symptoms of perimenopause, correct?
Yeah, I was just going to add that, as I think part of the problem in your case was that nobody took the time to really ask you enough questions. And I know we're going to get into this more, to really figure out, to make a diagnosis. You're coming in, so many people go to their primary care doc and say, I'm not feeling well. And they say, here's some Prozac, here's some Lexapro, without really asking what's going on and whether there are more psychosocial issues that need to be addressed through therapy, or whether it's, perimenopausal issue. They would need to be asking you, how often do you get your period? What other symptoms? And without asking that and just throwing an SSRI at you, it may have ended up working, because maybe with a big conversation that would have been appropriate. But I think it's that issue that they were talking about before, that we don't have enough time to really explore all of these factors.
Well, let's talk about.
Second, I do want to say it doesn't take a lot of time. Even in Dr. Minkin's 20-second visit, you can ask certain questions to really get at, has anything changed?
You're so right.
Right. And that way, a clinician should not be excused from not asking those questions. It is, and we'll talk about it when we talk about sex as well, we want to consider your health and mental health from a biopsychosocial model. There are psychological factors that you've reflected on. There are biologic factors. There are sociocultural factors. And it doesn't take a rocket scientist to be able to help a woman who's smart enough to be able to tease out which might be going on. She's more than happy to tell. You just need to ask. So make sure your clinicians are asking and find another one if they're not.
And speaking of, I just want to interject, speaking of not rocket science, I think one of the most important things women can do is super low tech menstrual tracking and just keep track of your periods. There are plenty of apps. Start keeping track of your periods if you're not doing it already, and keep track of the symptoms and when the symptoms are occurring around your cycle, and bring that information to your clinician.
Yep.
Because for me, that's where I get a lot of my information, and it's very quick and easy to understand where are your cycles. Not that we have to necessarily see cycle changes first, because we talked about that in the first panel, but definitely looking at mood symptoms around the cycle and what is the relationship.
All right, I want to ask one more question before we move on to different demographics. Dr. Alexander, more on the psychosocial effects of things, the different impact if you lose fertility choices, if it's 40 versus 50 years old when you go through menopause.
So I work with a lot of professional women, and part of the discussion with women who have had children and go into menopause, their response to it is different from women who have not had children. Sure. Because when you get to that point, there is a realization that I'm no longer able to procreate. I'm no longer able to birth. I'm no longer able to, you know, have another legacy walking around or what have you. So if you've never had that experience, your level of emotional impact is significantly different from someone who has, you know, 3 grown adults calling home for money every 3 weeks. So it is one of those things that we need to ask them.
That puts it in perspective, right?
It puts it into perspective, right? But when you're working with women behind closed doors, you want to ask those kinds of questions because their perspective on that phase of life is different.
Sure. Yeah, it makes total sense. Different demographics. Let's talk about this and if they can have different symptoms and risks as well. Dr. Jeffers, let me start with you. Hispanic women have a 2.5-fold increase in mood disturbances. Is that correct?
Right. So we can see differences in risk and odds ratios, and differences in the experience of mood issues. And we don't really know exactly why. We think that the racial and ethnic differences probably interact with some socio-demographic factors. There seems to be issues related to education, of course, financial stress. So a lot of other issues that play into this that I don't know that we have teased out yet, but we do know that certain groups are definitely at higher risk, including not just Hispanic women. That's the highest risk at 2.5. Black women as well as Japanese women are also at an increased risk.
All right, let's go on to talk about Black women, because I'm more likely to have incidents of depression, but less likely to seek help, correct?
Right. So when we were talking in the earlier panel about sucking it up, think about this misnomer of Black girl magic and how it's being pressed in our society to be strong. And that's like been for generations. It's nothing new. It's just a different term on it now.
Okay.
And so when they experience those things, it is like, okay, this is just another issue that I have to overcome. And in our community, this is what we say. If white people are experiencing it, we're experiencing it at 10 times that level because of access to care, information, education, and being informed and actually openly talking about it.
Right.
Because we've been conditioned, do not talk about what goes on in the home outside of the home. So you still feel alone and you feel like it's only happening to you when it's actually the exact opposite. We just need to talk about it.
And then going to ask for care is a whole different issue.
Asking for care is definitely, and because we're not listened to as well, because we're expected to be stronger, we're expected to have a higher pain tolerance, we're expected to do all of these things at significantly higher levels than our counterparts of another race. So we're not even asked the questions that women of another race are.
So how do we get started there? I mean, events like this are incredible, but you've got to get into community, and you've got to get into media
Get on TikTok.
talking about it. You got to
Get on TikTok and talk about it, because that's
I'll
where
tell you what, you're right, though.
that 30-second swipe is very. I mean, you can reach a lot of people.
Yeah. You're right. You're really right. I mean, you have to reach masses at this point because we're so far behind in this. There's no question about that at all. I said earlier, I've been in media for 30 years. I didn't say menopause until a year and a half ago.
Right.
Like that's a sin. That is a sin.
Talk vagina, clitoris, orgasm. The next panel, you'll really get used to that.
Fast forward to that. All right. Some good news. There are some multiple treatment options, and I want to talk about that. Dr. Kingsberg, I think you're going to talk us through the treatment options at a very high level, correct?
Sure. So at the highest level, you have various options, and please don't look at that as this is linear. It really is an individualized approach. There are many non-pharmacologic treatments for mood disorders, particularly if they're mild. But we talked about lifestyle changes for vasomotor symptoms, hot flashes and night sweats, but absolutely for mood. Getting exercise, even changing your diet, having a much healthier, for example, a Mediterranean diet can actually help your mood. Let's not talk about alcohol and other recreational drugs. And then there's cognitive behavior therapy or other forms of sort of behavioral therapies that are evidence-based. We have very good evidence that not only can cognitive behavior therapy help with mood swings and hot flashes, but it can help with so many other of the psychosocial issues. Then there's hormones, or HT, and so we have birth control pills for women who are perimenopausal. We talked about that before, particularly if you're at risk for pregnancy. That could be a real mood downer if you did not want to be pregnant. And then there's menopause hormone therapy. And let's not forget, and Dr. Stock can talk about
Everyone, please mute your
psychiatric
devices. Thank you.
medications. So the SSRIs and SNRIs, selective serotonin reuptake inhibitors, selective reuptake, norepinephrine reuptake inhibitors, are very effective for depression, sometimes for anxiety disorders. If you have much more significant psychiatric disorders, you really need to see a psychiatrist to talk about what those medications are. Sometimes it's a combination, back to my psychosocial model. Sometimes psychotherapy is really helpful, and I do this with my postpartum patients. Sometimes pharmacotherapy is going to be really effective, and sometimes the combination is the best treatment of all. It is individualized. It's not a one-size-fits-all.
I'm sorry, a combination of
Psychotherapy and pharmacotherapy and lifestyle.
Okay. Oh, and
Layering.
lifestyle.
I think of it as that layer.
Okay. So I have Dr. Jeffers. I think you're going to walk us through a case study, correct? And
Yeah,
bringing
absolutely.
a
So-
case study to life.
Yeah. So I can't really read that, but I do remember this.
Do you want this? That's all I got.
It's okay. I remember this patient very well because this is so typical of a patient that I would see presenting to our center. And she is a 48-year-old perimenopausal female. She had a prior history of depression, which was always worse before her period. So some symptoms of PMS, even to the point of PMDD. So she did have a history, and she had been in the past effectively treated for her PMDD symptoms with Zoloft, sertraline. PMDD premenstrual dysphoric disorder. It's just really like PMS on steroids is kind of the quick way to put it. But she had discontinued her medication at age 40, I think. And the reason for that is she was feeling better. And then perimenopause hit. And in this case, this patient had previously very normal periods. They were coming every 28 to every 30 days. They were textbook normal. Suddenly, she began to experience periods that came like every 21 days or every 35 days. And then she actually went 60 days without a period. So she had elements of both early perimenopause changes in her cycle as well as late perimenopausal changes in her cycle. So she now presents with these irregular periods and hot flashes that are the week prior to her period. But remember now, because her periods are so irregular, she doesn't really know when they're coming. So her mood symptoms are all over the place, and she doesn't understand what's happening to her. And she's really experiencing, she described it so perfectly to me. She said, I feel as though I'm falling off a cliff. I feel myself falling off a cliff. And then a few days later, I'll get my period. So in this case, she had a lot of anxiety. This was part of the cliff falling. And what we did is we worked together and talking about lifestyle, talking about layering. We talked about perimenopause a lot and this transition and the differences in the up and down of the estradiol. And in this case also, and this is where a really thorough history is important, This patient was drinking 5 cups of coffee a day. This is not unusual from what I see. Women are combating fatigue with more caffeine, and they're drinking it throughout the day.
Yeah, no, I'm one of them.
And that really was exacerbating her anxiety.
I want to talk about this. I want to bring lifestyle back into this all the time because we do talk about hormones a lot, but lifestyle plays a huge part in all of this, in every part.
Right. Part of my search for answers, I went to a holistic doctor. I went to female physicians. One female doctor cried with me and said, I cannot believe you were so misinformed. I finally ended up in a hormone clinic after seeking out plastic surgery to get rid of the abdominal stuff that was going on. And the doctor told me, you're overweight. He said, all of your estrogen, your body is looking for estrogen. So everything you eat, the sugar, is going to your abdominal area. He said, stop eating so much sugar, lose some weight, and then come back. Well, it was hard as heck for me to lose that weight. And I ended up at a hormone clinic, and that's where I got the answers. I was still overweight, but I wasn't as moody. And then I realized I was addicted to sugar. And so now I'm sugar sober, which is
it's a real thing.
I'm sugar sober.
How long is it back?
It has been 13 months.
Wow.
I'm sugar sober. Yes, I'm serious. Yeah. And I lost 40 pounds. Yes, ma'am. I did 40 pounds. But I didn't stop hormone therapy because I realized that was the catalyst for me having a clear mind to think through my options.
Exactly right.
I was so foggy during that process. No clarity. And being able to help other women because I was vocal about it on social media, like, this sucks. I can't do what I'm supposed to do. And women were just flooding to my office saying, help me.
Okay. Did we hit all that? Do you want to finish?
I just want to add something. In that first case, I think the other thing to be really focused on is that this is a woman who had a prior history of depression.
Okay.
And, I think that there are clues in her story. She had depression, and her depression worsened in the week before her period, which is, some people call it PMDD, we call it premenstrual worsening of depressive disorder. So if you have anxiety or depression as a baseline, and then many women do get worse symptoms in the week before they get their period, as well as then as they go through perimenopause. So I think this woman, she had stopped her Zoloft, and then she got this rush of the hormonal changes, these new hormonal changes, which is a stressor in and of itself. So I think it's important to sort of communicate to this woman what we think is happening. And certainly there's the perimenopausal part of it that's exacerbating things. But we also want to remind her that she has this history of depression, and we want to make sure that the depression doesn't worsen significantly. So this is a person I would absolutely tell to go back on the Zoloft and probably, refer to psychotherapy. I mean, I think there are times where one or the other may be more helpful or more practical for someone, but in my opinion, in an ideal world, both are the best option. So if we can do that, and we can't always, but again, it's this idea of communicating between providers. And I know Dr. Jeffers is able to sort of address all of these different pieces, but sometimes providers aren't. So making sure that we communicate that.
Talking to each other. All right. The case study 2 is somebody with no prior history of mood or anxiety issues. Dr. Kingsford, are you walking us through that?
Sure. So in contrast to one who, they're both 48, but first one had a prior history. She's got premenstrual dysphoric disorder or an exacerbation of her depression. This one is new onset. So then we look at the perimenopausal sort of causing her mood changes, and it's probably the hormonal shifts. It's new for her. So she's got irregular periods. She is more irritable. She feels down frequently. When we think about depression, and I think it's important to define depression, depression isn't sad. Depression is flat, right? When you are depressed, you have lost interest in things. You have no motivation to seek things out that you know are enjoyable to you. And that's what women will experience. They're like, well, I couldn't be bothered. And they're irritable. Sometimes they're a little bit, they have some more angry outbursts. She couldn't concentrate. So for her, we have to think back to the question of, do we want to try her on some birth control or some hormone therapy, or do we want to think about antidepressant? Or in my case, I would absolutely want her to have some psychotherapy to work on what are the situations in her life, because what, is she 48? What's going on in her life? That we may want to change in behaviorally to set up some different ways of her living her lifestyle so that she can improve whatever mood we can before we may put her on something else. But I don't want her, and here's where sometimes it goes awry, you don't want her to be in therapy forever suffering with symptoms.
Right.
It's the combination.
Let's talk about therapy for a minute, because I was actually talking to somebody yesterday about this at work, and she said, like, she's upset and mood. I could just kind of tell some of the symptoms, and I'm not a doctor, but I know what I was through, but she was not comfortable with seeking therapy. And that's a whole other hurdle, and then some people do not have access to that. And so how do you handle that? I mean, some people don't feel comfortable, other people don't have access to it.
Well, the access, thankfully, the only fringe benefit of the pandemic was telehealth. I am now licensed in 35 states. So yeah, so it is better access. Say my postpartum depression patients with babies, they couldn't come to my office. Now I can see them in their own home with the baby right there. So access is better, but you need mental health coverage. Most insurance companies and Medicare and Medicaid will cover it. So there is an access issue now. It's better. It's still not, but the stigma of therapy remains. And so that's part of the education, to be able to say, you're entitled to good mental health. It doesn't mean you're weak. It's not a pick yourself up by the bootstraps and how dare you need therapy. This is a tool to help you become your best self.
Can I interject on that? So this is what I'm so glad we're in a room full of women. Sorry for the guys that are in here. But how many of you go to your annual physician appointments? You go for your well women's check, right? You go to your dentist twice a year, right? Make sure your teeth are looking good. A lot of you have on glasses, so you're going to the optometrist at least once a year, right? When you move into a new city, do you look for a beautician, a stylist, or a colorist, right? You have to get that. So how many of you go to your annual psychotherapy appointments? How many of you check in once or twice a year? So then I ask you, why is your hair care more important than your mental health? When you tell me that you're not going to go to therapy.
But it puts it in
It puts it into perspective, right?
Right? It's almost embarrassing to answer that.
Right.
Yes.
I was just going to say, the other thing about therapy, there's a big stigma for sure, but I think there's also a misconception that therapy is like Woody Allen's therapy, where you go to a psychoanalyst 5 times a week and lie on a couch and you're in therapy for 30 years or whatever. And now we know that, there are scientifically proven types of therapy that really work, as well as medications for certain types of psychiatric disorders. And so, there's a ton of therapists out there. Some are good and some are not so good. But I think if you're looking for a therapist, you want to ask them, you want to tell them what your problems are, but you want to also ask them what approach are they going to use and why are they using that approach, and really listen to that, because things like cognitive behavioral therapy or dialectical behavioral therapy or EMDR have been shown to be really helpful for certain things. So I think there is that stigma too, that maybe your colleague had this fantasy of what therapy was, or was embarrassed about what they might have to tell their therapist. And it's really not sort of that polar.
For the most part, it's short term. My goal is to become obsolete. And that is, I managed to become obsolete a lot of times. And then there's relapse prevention. So I like to see people come back every 6 months, every 12 months. And I do I say, you go to your dentist, and I'm much less painful, mostly. And that is really about coming back to make sure that, because they think about it. When they know they have to see me, they'll think about, well, what's going on in my life that I'm not using my tools very well. And that also keeps them on task.
All right, let's hit study number 3, 56-year-old menopausal woman, newly anxious, sad, tired all the time, sporadic hot flashes, waking up every morning at 4 a.m. and can't get back to sleep.
Well, can we talk about sleep for a minute? And
Sure.
the impact of sleep and mood. So that's a kind of very bi-directional.
Just 1 second. Can everybody hear? Can everybody hear everyone? Okay. All right.
So I don't have to hold it up like this.
Maybe we can crank up your mic a little bit.
Okay. So back to my original strategy of holding it. Well, look at this nice little menopause puzzle. That is such a great slide, because it really shows the interaction of all the potential symptoms and how do you know which one you're going to pick. And I think talking about the layering, you kind of pick out which is the most prevalent symptom, which one started first, and that will help guide how you and your clinician want to go about treatment, right? Because if you are not sleeping, that is absolutely going to put you at risk for a mood disorder or anxiety. On the other hand, I see lots of people who have a depression and then they're waking up at 4 or 5 in the morning with early morning awakening. And they're, well, is that menopause? No, that's the depression causing early morning awakening. So you need to think about that. And trust me, for the weight gain, that would be depressing. And panic attacks are very common, but is that really a hot flash leading to panic? Oh my God, I'm sitting here on stage and I'm about to have a hot flash. Am I really panicking, or is that? So you need to tease out which is which, and women are smart. They can figure that out, and that will help guide you and your clinician as to treatment approaches.
Let's go back to sleep though, because I think that is something to address. And I was actually thinking about that. What does come first? Is it sleep affects mental health affects sleep, or it could be any combination, which is why it's it's a puzzle.
It could definitely be any combination. And like we were saying on everything, it's so individualized.
Yeah.
And I don't think enough of us slow down to figure out what's really happening with our bodies until we're in crisis mode. Everything that happens out of the ordinary is an alert to you that something needs to be reset in your body. But from my experience, if you're not getting enough sleep, something is going to show with your mood.
Yep.
You're going to be more irritable. You're going to be sadder. You're going to have the anxiety. Something is going to show from a lack of sleep. And think of how many people are not getting enough sleep anyway. And then when you go into menopause, it's exasperated.
And then you're down in the coffee, and then you've got the cycle that starts.
Yeah.
Alcohol is really disruptive of sleep. And in my experience with menopausal women, particularly in the last 9 months, we're seeing a lot of women reporting to care that didn't do anything and were suffering during the pandemic with hormonal symptoms and just suffered through it. And now they're presenting to care. And if you are actually checking in with how much caffeine, what's the diet look like, how much alcohol are they consuming? And we're picking up a lot of women who are consuming a lot of alcohol that's really making the situation worse.
So I'm curious, and I don't know about any of you, but does alcohol and caffeine, do they start affecting you differently in these stages than you did when you were 20, 25 years old? I mean, I know for me.
It can exacerbate that
The
caffeine,
symptoms.
because caffeine activates the sympathetic nervous system. When we lose estradiol, there tends to be an activity of the sympathetic nervous system. So it exacerbates that. And then alcohol interrupts sleep. It disrupts REM sleep. And it also has obviously a depressant effect.
And think about red wine. How many of you drink red wine? Okay, anybody notice that they have more hot flashes after red wine and the tannins? Yep. So when you're 20, you might get away with it, but when you're 50, you're going to have a hot flash.
And then that goes to sugar.
The sugar.
The red wine, the sugar, and that increases hot flashes too, or increases the feeling you get with hot flashes? Does sugar do that too?
Exacerbates any blood
All the
sugar,
levels.
the blood sugar levels going up and down and up and down. Yeah.
Let's talk about testosterone. We talked about estrogen. We talked about progesterone. I want to address testosterone and either where you stand on it, or thoughts about it, or risks about it. So whoever wants to jump in. Do you want to start?
I love testosterone. I'm a patient, and I go every 2 to 3 weeks and get an injection. So
Okay.
You would have to seriously talk me out of taking testosterone for the focus, the energy, the strength, my muscle mass. Like I feel different. I feel stronger, mentally and physically. So I think it was definitely a good move for me.
Okay, I'm going to jump in here. As a past president of North American Menopause Society and ISWISH, we actually have some global consensus guidelines on testosterone, and we do know that it can be effective for hypoactive sexual desire disorder. We'll talk about it in the next panel, which is low desire. It is not, there's no indication for any other condition yet. And unfortunately, the injections, which is also going to the idea of hormone clinics, you really need to be very careful. No pellets, no injections. What is recommended is going to be a topical gel. The FDA products for men, because there are no FDA products for women, testosterone products, only for males, but we know they are FDA approved. And so we take those versions. So there's a testosterone gel, and we use what would be 1 day's dose for a man would be about 10 days dose for a woman. Okay, so
Okay.
you've got a little gel that would be 1 day, and that packet should last a woman 10 days. Put it on the back of your calf or on the back of your shoulder, someplace where there's not hair, and what you're trying to do is to increase your testosterone levels to what they are in a premenopausal woman. We are not creating super physiologic doses. We are putting them back in a premenopausal level, right? And for women who think of a little is good, a lot is better, no, we're just trying to get you back. And so if it's working for you, you would know it in about 12 weeks. And after 12 weeks, if it's not working for you, don't do it. You need to have your blood levels measured. Here's where you do want your blood levels measured. Beforehand, it won't tell you anything. There's no blood level that will tell you whether you will be a responder to testosterone for low desire. But once you have been on it for several weeks, you want to make sure your blood levels are in that premenopausal range. Okay? Sorry.
Complete agreement. I think one of the issues to be aware of is that the injections, and in particular pellet therapy, is very dangerous. And the reason for that is once those pellets are inserted, there is no control over the dose that you're getting. And very, very often, and I'm concerned about the number of patients I'm seeing at our center who have been to clinics and come in with pellet therapy. We can't get the pellets out. And I have had to test hormone levels, which I rarely do. But in this case, I have had to test them, and I find their testosterone levels are extraordinarily high, can be very dangerous for many different things. And it can adversely affect cholesterol levels and risk for coronary heart disease. So I think it's something we have to be very cautious, very careful about. Transdermal. I'm glad.
Well, here's the thing. Mine are very low. I do want to make that known.
Yeah.
We do keep my levels very low, and I get my blood tested every 90 days.
Perfect.
Yes,
what
we
you
are
want.
definitely monitoring it. Yeah.
That's what you want.
You know, I think it's important to talk about, though, because it is the one thing that is not talked about as much. And so women do, you know, if you're going to somebody that you walk in there and you feel comfortable with, and you feel like they're giving you an answer, you're going to look better, you're going to feel better, you're, you know, you have low testosterone, you know, it's going to change your weight, it's going to change your muscle, sign me up. Without the education, right, about it.
This is really the key, that the theme that we've been talking about is
Yeah.
women are desperate. They don't know
Exactly
where
right.
to go.
Exactly right.
And they don't know how to get help and what is the right kind of help. And so really that's one of the big issues. And the other issue that we have to be careful of that has already been brought up is the proliferation of products of people making money off menopausal
And
symptoms.
that's what's going to happen. With us talking about it more, people are going to see this as an investment. They're going to see it as a money-making opportunity. So the more informed we are, the more we can tell our friends and family, like we were talking about, the next generation of women, to say, oh, no, honey, you need to go read the research on that.
Right.
All right, let's talk about this. I want to talk about accessing treatment, because I think that that's important. There are barriers to getting help, you know, and I think it's important that we have messages for patients and for women. We're going to start taking questions right after this. But how do you access treatment? Where do you start? If you know, it's very easy for us to say, like, you know, you need to have a therapist, you need to have a gynecologist. But if you've gone to a gynecologist since you were pregnant or, you know, since you were in your 20s, and that's the gynecologist you go to, like, that's what I was doing for a long time. They never mentioned menopause, ever, never. I had endometrial polyps removed 2 different times. And I find that in a lot of cases. Where do you go to start accessing that treatment so you feel comfortable that you're with the right person?
Well, I'm always going to promote the North American Menopause Society. That's easy enough to just go on menopause.org and find in your zip code a NAM certified menopause practitioner. Easy enough. And if your clinician is not asking you about things like hot flashes, night sweats, and vaginal dryness and pain with sexual activity, because we'll talk about that the next panel, then you need to find somebody who isn't busy delivering babies or wanting to do surgery, but and that's part of the other problem with menopause practitioners, they don't make a lot of money off of women because they're not doing all these fancy procedures, thank goodness. And so you need somebody who's willing to be invested in midlife women's health.
I feel more hopeful that we have started this Center for Midlife Health and Menopause at NYU. And it's a university research based model that we really, I mean, as a co-director, I started it based on patient-centered care, based on informed decision-making. And I think that that's really important because we do have the opportunity to collaborate across many disciplines. And I think that that's an excellent model. Is it perfect? It's not. It's a bumpy road, and we're doing something that's new and different, but I believe in the model. So I think models of interdisciplinary care at major academic medical centers is a great place to start. And the beauty of that is it's not a concierge type of practice. I mean, women are paying thousands of dollars to go to menopause specialists, and it really decreases access. It doesn't improve access. So we do take all different insurance plans, and I am committed to spending, 45 minutes with my patients. So, as long as we can hang on to those models, and it's not easy, if they're not easy to set up, and they're probably not going to be easy to sustain, but I think that that gives me hope for menopausal care.
Well, I think one of the problems that's happened during the pandemic is that there's such a shortage of good, therapists and psychiatrists and, OBGYNs. I mean, it's just so hard to access care because the waiting time is so long. And so that's another problem. You may actually want to get into therapy, or you may want to see a psychiatrist, and there may be 3-6 months before you can. And I think that would be a situation where you may want to go back to your primary care or your OBGYN and explain that to them. They may know somebody, you may have a friend who knows somebody, but they may be able to start the process until you can get to that specialty. Because I agree with Dr. Jeffers. I think that in an ideal model, having collaboration between people who specialize in different pieces of this is the most ideal thing, but it's not always so easy to do that these days.
What medical practitioners can typically help? And if we talk about, we're going to a GP, a general practitioner, OB, I had somebody drew my blood that wanted to, start me on estrogen. What are the medical practitioners that can most likely help?
Your primary care physician, that's always our first stop.
Yeah.
But the OBGYNs
And there are primary care that specialize in women's health.
Yeah.
So that's
Okay.
also, if you're thinking about primary care, think about somebody who does women's health, because it is not the same as men's health. And so, and not just women's health, but midlife women's health. And that's really where you want to narrow that focus, whether it's a gynecologist, and I say OBGYN, but really you want gynecology because OB is done, and or a family practice or nurse practitioner or primary care who specializes in midlife.
I want to just open the floor, and any of you jump into this, but we started this off saying, like, how can I feel normal again, or what's wrong with me, and how can I get back to who I was? That anxiety is real. Anxiety is real. Not even knowing who you were before that is real. Lifestyle plays a huge role. Are you seeing lifestyle, and what parts are we talking about in particular? I assume nutrition. I assume exercise. What parts of nutrition and exercise are you focused on right now in each one of your specialties?
For me, it's the sugar.
Okay.
Especially with Black and brown women, so many of our foods have hidden sugars in them. And then we cook with a lot of sugar. That's just how I was taught to cook.
Okay.
And so like I told you, I'm very vocal about my journey, and losing 40 pounds was a huge, my audience noticed it and they wanted answers. But I don't think we realize just how much that sugar disrupts our mood and our ability to concentrate and sleep when you're eating a brownie before you go to bed. That's serious what we're doing to cope. Just one of those things we're using.
And how did you start doing that? Because people, I'm sure, ask you all the time, how did you do it? What did you eliminate?
My doctor said that I was pre-diabetic. That was the first thing, scared me, had me taking a shot in my stomach once a week to lose weight. And then she said, keep messing around and you're going to be on high blood pressure medication. So when I came in, she prescribed metformin, tear dropped. She said, when you come back, you're going to be on high blood pressure medication. So I left the doctor's office and I called someone and said, that was my 911 call.
Yeah.
And from that point on, I got serious about it, and I don't eat sugar
I
anymore.
sat next to her at dinner last night, and I can absolutely attest to how she eats. I felt terribly guilty.
What'd you eat for dinner?
A salad. I had a big salad and I ate some protein. I did.
One of the things that I do with patients after I've done the history and looking at caffeine and looking at amount of alcohol is I just do a 24-hour diet inventory. What did you eat for breakfast? What did you eat for lunch? What did you eat for dinner? And it is amazing. I get so much out of that information. And so what I try to do within that 45-minute visit is give them just some little things that they can do. And sometimes it's little tweaks that add up to a lot. And I don't want to take anything away quickly from people, but I can help them decrease alcohol slowly, help them decrease caffeine a little bit, help them more toward a Mediterranean diet, which starts off really with protein in the morning. So rather than reaching for cereal or reaching for a bagel, what can we find? Can we do Greek non-fat yogurt with some walnuts and some blueberries to get the antioxidants, the omega-3s, the protein, the calcium, trying to show them where they can get the most bang for their buck and stabilize their blood sugar.
I think exercise is also really important, and so exercise doesn't mean training for the New York City Marathon or, but it just means getting out there, getting your heart rate.
Yeah.
And we all know that when you exercise, you get an increase in your endorphins, which is going to make you feel better. And then also, in perimenopause, it's good for your bones and your muscles. So I think, there are some people who love to exercise, that's great. But for people who don't, I encourage all my patients, just go out and take a walk, whether it's a perimenopausal person or someone who's depressed at another point in their life. Just go out, even if you don't feel like it, for 5 minutes, 10 minutes. And little by little, most people will start to see that it has an impact.
There was just a new study, 11 minutes of, moderate to fairly intense exercise. 11 minutes can decrease all-cause mortality and
have to
improve
be able to
mood.
find that in a given day, right?
Yeah.
All right, let's get to some of the questions because we have about, I don't even know, I can't see, but anyway, we have some time for questions. All right, let's talk queer, gender, non-conforming people with menopause. The menopause movement is heavily feminine. It affects depression. It is disorienting.
I can speak to that. I agree. And I think that we do always talk about women's health and we talk about menopause as a female experience, and that's not true. Anyone who has ovaries will experience menopause and will experience hormonal changes. So I agree that we need to take a look at that. We need to open up our language, and we definitely are very sensitized to that at NYU. In particular, I think everywhere should be sensitized to that. One of the things we do when we see our patients for the first time is talk about how they identify, what is their sexual orientation? Do they identify? Are they biologically female, and how do they identify? So I think it's really important to take a look at that right from the beginning. I want people of any orientation to feel comfortable coming to me because anyone with ovaries is going to experience menopause. So thank you for that.
Are there any questions out in the audience right now? Yes. Oh, hold on one second. Let me see if I can do this. Thank you.
Good afternoon. I'd like to know if there's an age limit and/or a cutoff period.
Restart the question. I'm sorry, I didn't hear the first part.
I'm asking about, is there an age limit related to testosterone therapy? When is there a cutoff age, or when would you recommend that that type of therapy starts?
For testosterone, remember, it's for hypoactive sexual desire disorder, so there should be no other indication for it. But no, you don't have that same sort of position statement on within 10 years of menopause. But it is a hormone, so you need to be careful and talk to your clinician if you're 70 and wanting to think about starting something that is de novo. But there isn't the same cutoff and in terms of how long you should be on it, you might think about trying to come off it after, again, several years. But what we know for low desire is once you come off it, it usually will return to low desire.
One thing we didn't have a chance to really address when you think about, I know you guys are going to talk about this more in the next panel, but this idea of low desire, sexual dysfunction, it can be a consequence of the hormonal changes, but it can also be a consequence of depression, right? And it can also be a consequence of the medications that we use to treat depression. So that puzzle really, it is kind of like a tornado. And so, testosterone is used sometimes to help women when they have, low desire or sexual dysfunction. But I think, again, we want to tease out what's the reason, and are there other ways that we can, address this problem for women or even for men who are on antidepressants and they really work and they're having, sexual dysfunction. There are some things we can do. They don't always work, but, you can decrease the dose before you want to have sex. It's not that practical, but you can try to do that. So there are a lot of things, but again, you want to look at the big picture and kind of not just look at one point here or there, because everything sort of falls back on itself and, it becomes kind of a vicious cycle.
Yeah, and I think something that we didn't address that I meant to interject on is the combination of using some of the SSRIs, SNRIs, and estrogen can be extremely beneficial, particularly for perimenopausal women.
We're saying antidepressants
and that combination, because of the way, as we lose estrogen, estrogen really modulates the impact of neurotransmitters in the brain. And I think we brought that up in the first panel. And so they can often work very effectively together, not necessarily for sexual dysfunction, but that we can get a very nice effect of stabilizing hormones as well as improving mood with the two.
Okay.
Well, also, sexual dysfunction is either going to be difficulty with orgasm, thank you to SSRIs and SNRIs, or difficulty with desire. So it can go in both directions.
Sometimes SSRIs affect your desire too. I mean, more likely affects your orgasm.
Right, that's what I said.
Yeah, exactly,
It
right.
can go in
Yeah.
two different directions.
Talk a little bit about the mental adjustments that you have to make when you hit menopause to all of these concerns. I think that's maybe the hardest thing, that you're addressing all of these new changes in your life, and you have to mentally wrap your mind around this new reality that you're facing in all of these different areas. I think that's the most challenging thing, really.
I urgently tell women to just go to therapy. Just have a space where you can talk about it, where no one will judge you. They won't hold you to this standard that you're expected to hold outside in your world of influence. And part of it is the awareness. You may start talking about something, and then it will trigger your therapist to say, "Are you going through menopause? Or have you talked to your physician about this?" But you're thinking it's just general anxiety, or I'm feeling, overwhelmed with things that you've been managing for 10, 15 years, but all of a sudden it just seems too much. There was an episode years ago on Will Smith, Fresh Prince of Bel-Air. Yeah. They actually talked about it, emotional balance, with one of the sisters that was going through menopause, and how irritable she was and how she kept going off on everybody. And they just had to take a step back and say, "Girl, you need to go get some help." But who actually says that to their friends or their sister? You're so afraid of offending her. But maybe if we said, "I think you should go talk to someone," and not make it look like you need to go talk to somebody.
Well, you're right.
But beyond that, though, is acceptance. And so that's a subset of cognitive behavior therapy, is acceptance therapy. So you're talking about the struggles of, now I'm midlife, now I'm an older woman, and what does that mean? And that really is taking some time, and I love to do that in therapy. Well, what does that mean to you, and why, does it need to be, you talked about getting back to you. And sometimes it's moving on and being a different you, sometimes better. I do think that postmenopausal zest is a real thing.
Postmenopausal what? Zest?
Postmenopausal zest.
When does the zest happen?
I'm in zest.
I want to say a couple of things. I completely agree. I also think that as women, we keep a lid on our rage a lot.
Sure.
And I also think we do too much. And I think that menopause is a wake-up call. It's a wake-up call for us to really say, I need to think about how much I'm doing, and how much of it is something I really want to do, how much of it is something I'm doing for myself. How much rest do I need? How fast do I really need to go? And do I really need to do all these things? And what am I angry about? And let me take a look at that. So I think that there's definitely the acceptance. I think there's definitely getting help. And I think it's also part of culturally what it is to be a woman and what it means to be a woman getting older in this culture as well.
Because we live in an ageist society, right? So, you know, the representation of going through menopause means you're getting old, and that's a bad thing, you know, in our society. But I think, you know, it can be a positive thing too, and I think that's what you guys are saying. So it's not all negative, but I think some of that is also reframing. Like at any transition, you know, when teenagers, when girls first get their period, they're like, oh my God, you know, it can be a terrible thing, but then you can reframe it as a good thing. When postpartum, when women have a baby, the first couple of weeks after it's stressful, difficult thing, and new moms are often like, I want to just get this baby back, you know, and you know, this is a new phase of your life. So I think we can do the same thing with perimenopause and menopause, but I think we tend to not talk about that as much, and which is why it's a great.
I know, right?
I think there's a question. Yeah.
Address the fact that this is, the psychosocial thing is real, and that women in this heteronormative construction that we live in become obsolete, right, as we're growing older. And so not only are there physical things that are happening to us, but there are psychosocial realities too. And that brings me to my question. I work with women in leadership positions, and they are seeing that even as managing directors, their roles are shifting a great deal as they go through menopause. And the conversation in leadership and equity and inclusion needs to include the conversation about the realities of menopause. I think we've gotten there a little bit with maternity, but we need to start addressing. So even though we haven't been talking here about the men in the room, we need to start bringing this conversation to the men in the room.
Absolutely.
You know, there's a myth. Do you remember the myth of the empty nest syndrome? Right? That it's a myth. It's really, you know, the idea that women get depressed when their kids leave home. Well, we know that what's the truth is it's not when they leave, it's when they move back in. That really is the.
You know, though, I am encouraged by seeing a room like this with people open and asking questions out loud. I'm working on a documentary, and I've been collecting videos of women, video diaries, and the diaries, people can finish each other's sentence, you know, of what they've been going through through the course of menopause, and then the menopausal zest, which I think is exciting, and it's nice to hear more about that. Which is
Margaret Mead
yes,
coined that term
a
long time ago.
It's what we need to talk a lot more about for sure. Okay, so this is interesting. Panelists say find experts in New York City, one of the biggest cities in the world. Clinicians barely exist. Nationally, the search would be impossible.
I'm really shocked by that. Wow, because I see so many clinicians coming into the field.
Yeah.
As well, clinicians are being certified across state lines during COVID, being licensed in multiple states. But I mean, it could be that they're stacked.
I think it's a supply chain issue, quite frankly. I feel like what is happening in healthcare is what's happening in so many different industries. And that is that there's this pent-up demand of patients seeking care, that want care, demanding care. And we have a shortage right now of clinicians. We had a lot of clinicians that retired. We have people that got burnt out and left. And I think that we need a pipeline of new clinicians, really, to meet this demand. So I think this is a little bit a supply chain issue. Really.
They also went into private practice, which does make it difficult for access of care because private practice is more expensive.
Like a concierge service
yes.
or something. Okay. The other question is this, and I think this goes back to what we were asking at the end, what medical practitioners can most likely help. I'm just wondering, is it that people, maybe, I don't know, maybe this doesn't make sense, but maybe we need a title so people understand who deals with midlife menopause. I mean, it's not all OBGYNs that you're going to feel comfortable with dealing with menopause, correct? Some might not, we've already said, some have not been trained in school with it. And I'm just wondering if people get confused because there's not a practice that just says, I deal with midlife menopause.
We have a certification.
Sure. Oh, no, I understand that.
So
But I'm saying, but not everybody, right. But not everybody does. I'm wondering if that becomes more common, do you think?
Yeah.
Or necessary to be more common.
Yeah.
I think, if more people did that, it would make it easier to access the care.
To understand who to go to. Okay, what do you think about the new one-stop shop clinics offering things like MHT and Botox under one roof?
I think they should be separate.
Okay.
And I don't think the answer to menopause is to fix everything cosmetically on the outside. I think we're talking about building things from the inside out.
Okay.
And really working on mental health, things that, maybe aren't visible. So I think I don't like the emphasis. A place that would do both of those things to me is emphasizing perhaps the wrong thing.
Didn't we hear in the last panel if they're selling something and it's kind of you be careful.
Okay. Go ahead.
Okay, hi. I love how everyone is addressing the complex biopsychosocial. I'm a psychologist, and I have recently started a group that it brings in educators to talk to women in various disciplines on menopause. And then we have a therapy group around that. And all of the issues that you're bringing up are top of mind for people, including how do you find the right doc, who's going to listen to you. But I also wanted to raise, I have a specialty in eating disorders, and some of the concerns that I have and that some of my patients are having are tied into what people are talking about in a number of ways. One is, what are the expectations around aging, and how can we shape that so that you're not at 50 and 60 trying to look like you're 30 and then feeling badly about yourself for that. And then also being mindful of restrictive diets that do reinforce some eating issues. And there is another peak, we see it in younger women, and then we see another peak in midlife around eating disorders and exercise compulsions. And so I want to be careful that we're thoughtful about the messaging around weight management. So if you could speak to that, that would be
I think that's a really good point as it relates back to your first question, like, why am I not feeling like myself? And to acknowledge that myself changes across our life cycle, right? And so, again, I think that's why therapy is so important, because yes, your body is not going to look the same when you're 50 as when you're 20, whether you have extra weight or you don't have extra weight. And so this idea of acceptance is so important. And the idea of your future. I know there was a question that we might not have gotten to about grief, and grief can play such a big role because people's lives just get changed, right? When they're 40, when you're in your 20s and 30s, most people are fortunate enough that their life is, some people aren't, but kind of plodding along, and you can plan this and this will happen. And then get into your 40s and 50s, lots of things happen. And so, acknowledging that we can pivot and change and that we have this sort of ability to sort of be more resilient, I think is really important. And so therapy, I think, is a huge way, whether it's groups or individual or, to talk about that.
Yeah, to address those things. Yes.
So one of the things that I think that you're all talking about is helping women advocate for themselves to be the best patients they can be. But one of the things that I think is missing, I'm a systemic sex therapist, and I do a lot of couples. And what I find is a lot of women come in on their own because they feel it's my body, my problem, I'll fix it. And I think one of the missing pieces, and I always ask them, is would your partner be willing to come in at some point? Because I'm sure there's an impact on your relationship and on them.
Right.
And I would love to hear your thoughts about inviting partners into the room when they come and consult with you.
Yeah, we had a really good conversation about it. I mean, just from, we're 30 years in this year, and it just got really bad. It got really bad. And that was part of it. I was like, I don't think you understand what's going on here. This is not something that I can control. And so at that point, I think that was a wake-up call for him to say, oh, shoot, I did not understand everything that was going on. And it's one of those things with relationships. Do you think that your spouse or your mate is a mate whisperer, that they're just going to understand everything that you're saying without communicating it? So why are we not communicating about such a pivotal moment in our lives and thinking that we're the only ones that are being impacted about it? And it's not just our spouses, our mates, it's actually our children. Someone asked about the workplace. Like, a lot of people are impacted by your mood shift because they know who you were, and they're thinking, what is going on with her? And so you may lose your job You may lose your marriage. I want someone to do a study on how many women decide to get divorced during menopause, because you do get to that point like, I don't have to deal with this anymore. The rage.
I was just I think there's the flip side of it too. So when you have someone who's coming in and saying, my body's so different, I don't feel appealing, and talking about bringing a partner, and sometimes women are surprised because partners aren't really impacted the way they think they are, which kind of goes back to the eating disorder question, right? So, we can have all these fantasies about how we should look or how we should be and how that might be negatively impacted. And unless you have the actual data from the partner, you don't know. Is it worse? It could be a period of time that's worse, but it could be time where you're bringing all that on yourself, and it's really about the communication. So I don't know if you see that too, but I think that could happen also.
If there is a partner.
Yeah, or if
they're not always a partner, not always the same gender.
Right.
Go ahead.
I am a physical
Can
therapist.
you put the mic closer to your mouth?
Yeah,
Thanks.
sorry. Good morning. I am a physical therapist, and I specialize in women's health and pelvic health. And thank you. And we are a growing field across the nation and across the world. And mental health therapy and physical therapy has a great opportunity to be covering all of these things. I feel a great privilege in being able to bridge the gap between the 20-second MD appointment and the struggles that are happening in real life. And because we have a little longer time available to be able to work with our patients and listen for an hour session, 40-minute session, whatever, we can really be that person. I hear the access difficulty and who do we tell? But this is an opportunity between mental health therapists and physical therapists to be able to tell your story, and we can perhaps help you then triage to the right people or to some of the strategies available. And physical therapy has the great ability to be able to treat head to toe and all between. That's my kind of personal slogan. But
pelvic floor physical therapy has changed our world. Yeah. Really, it has. Pelvic floor physical therapy, and we'll talk about it in the next panel. So thank you for bringing that up. Yeah. Absolutely.
To her point, I'm also a physical therapist, board certified in women's health and certified in pelvic health. We do a lot for the pelvic health. And I think what she's saying is that holistic point of view of wellness, how to keep the muscles, the bones strong, beyond pelvic health.
Sure.
So
the more than one thing.
With the American Physical Therapy Association, and physical therapists are on this. I mean, they are on the menopause bandwagon, and we keep pushing it. So know that we are on it.
Yay.
I want to ask this one question because you addressed divorce and women in work. Somebody said this, and I'm curious what you think. There's ageism in the workplace. Isn't addressing menopause at work biasing women even more?
It's an interesting dilemma.
It is.
And the UK is addressing it before we are.
Yeah.
And they really are working towards having a policy that will protect midlife women and menopausal women. And it is, will that create more bias to the leadership, or will it protect? My hope is that it will be more protective, that we have terrible maternity health policies in the U.S. We're the worst country. And we have terrible midlife policies. So I get it that it may look like, well, we have, they're weaker, but I do think having those policies in place that allow for changing the temperature or how you dress or time off, I think can be very helpful.
Yeah, I do too. I know I'm in the process of working on some of that kind of stuff myself, and I'm curious about that because I look, it affects you at work, and we're working later and later in life, and we are in a prime of our career, oftentimes as we're battling a lot of these unknowns, a lot of this transition. Okay, what is cognitive behavioral therapy? Someone's asking.
CBT, cognitive behavior therapy, really is it's relatively short term. It's very pragmatic. It's looking at how your thoughts and feelings and behaviors impact your mood or anxiety, and shifting them in a way that can change both, psychologically and even with neuroplasticity will change how brain function is to improve mood, anxiety, sexual function. So it's very pragmatic. It really is about challenging some of those very ingrained thoughts and beliefs that you don't even know that you have, that are sort of automatic, and helping you see them and challenge them and then shift them into a more positive direction.
All right. Let's do one more question because then I'm getting a wrap. So, right in the yellow scarf, or is that yellow? I can't. Green? I'm sorry.
Can't hear.
Can you speak up louder? I don't know if there's a mic.
Menopause affects half the population, and every internal medicine, every primary care doctor, half of their patients will probably experience it. Every gynecologist, unless they specialize in obstetrics only, will have menopausal patients. So on the side of medical education, I actually think we need to reform our medical education and training systems so that everyone in these primary care specialties can handle basic menopause. And yes, there is a lot to it. So we cannot be psychiatrists and pelvic floor physical therapists and marriage and relationship therapists all in one, but we should be able to provide basic menopause care, leaving the specialists to handle the really difficult cases.
Thank you.
And I think, we're not there yet. There's a lot to be done. There's a lot of systemic barriers to that because unfortunately we have a medical system that rewards procedures and 15-minute visits and single prescriptions, and you cannot do menopause like that. So before we get there, I think my sort of advice would be and I think somebody said it on the panel, to really prepare for that visit. There is a lot of information online. Some of it is good. Some of it is not so good. There are platforms that are listed here. And again, full disclosure, I do have the privilege of working with one of those platforms, Electra Health. But there is valuable information out there. And if you access it and bring it with you to that 15-minute appointment, it's going to be that much more effective for you.
Thank you so much. I think on that note, I appreciate everyone's questions. I know we have more panels today, but thank you all for being here and being so open and answering questions that are just, coming in. I appreciate it. Thank you.
We're gonna take a can you guys hear me? We are going to take a 15-minute break. We know we have hold on 1 second. Tamsen is going to be departing. She has a previous engagement, and we're going to have a new host for the third part. But I just want to thank her. She just did an incredible job here. It's not easy to do this, and she does it flawlessly. She makes it look so easy, and it's not. And we just, at Let's Talk Menopause, just want to thank you from the bottom of our hearts that this was amazing. And this panel was fantastic. And there's more to come, okay? And the next panel is on sex. Okay? Thank you so much. All right, everyone, if we can take our seats. The 15-minute break is up, and we are going to get to some sex. And I think everyone wants to take their seats to listen. Make sure that you put your questions in on Slido. I know that there's so many questions and we have not answered all of your questions, and we are so sorry for that. We really wish we could answer every single person's question, but I promise you that we are going to really try to get to all of the questions, if not today, then in other menopause talks. So Let's Talk Menopause has monthly virtual events online. You can go to letstalkmenopause.org/talks and listen to all of the past talks that we've had. We've had one on weight and menopause. We've had one on race and menopause. We've had one on the sexual side effects of menopause. We've had one on the urogynecology, the urology, the urinary leaking. I can't even remember the rest, but there's a lot. We've had 12 months worth of menopause talks virtually. This is our first one live and virtual, and we're so happy that everyone has joined us. And is everyone seated? Okay, so we're going to get started. this is our third panel, and this is addressing the sexual, urinary, and vaginal symptoms of menopause. And let me just tell you that this panel is freaking unbelievable. So you guys have the best, I mean, all our panels are unbelievable, but this is like the best of sex. Seriously. So
I agree with that.
I know you were gonna say you're good at sex. So I'm going to introduce.
Say that, but
I'm going to introduce Dr. Lauren Stryker. She is the founding medical director of the Northwestern Medicine Center for Sexual Medicine. She has written lots of books that you probably want to get. One of them is Slip Sliding Away, Turning Back the Clock on Your Vagina, a gynecologist's guide to eliminating postmenopause dryness and pain. She also has a podcast and lots of other things in the works. So I'm going to let her take it away and introduce the rest of the panelists. Thank you so much, Lauren.
Well, thank you so much. And thank you so much for saying that we're going to be the best panel, because now we're going to be the best panel, right? But we're going to start with a couple of quick survey questions. Super quick. Are we putting the survey questions up there? The first one is, has any doctor or any other medical professional ever in your life asked you about sex? And I don't mean about, do you need birth control? Okay? That question up there? Give you a second to do that one. And then the second question is, has any medical professional ever asked you about your ability to have an orgasm? All right, so let's see what the answers are. It's not coming up. Oh, wait. Oh, there it is. No, never have they asked about an orgasm. And the other one talked about sex. That one's not coming up. Well, we'll assume that's the same. So none of this is any surprise to this panel. We know that. We know your doctors are not talking to you about that. And that's why we're going to go there. We're going to spend the next hour or so talking about vaginas, vulvas, orgasms, bladders, and specifically all of those parts that no longer have the benefit of estrogen. Now, before we get to the panel, I want to do just a quick definition. We threw out the word earlier, genitourinary syndrome of menopause. Genitourinary syndrome of menopause is also called GSM. I think we have a slide coming up on that. Jessica, do we have the, nope, back. Okay, so GSM, basically genitourinary syndrome of menopause, and this is a woman from the side, and we see the back side where it says back is there on the left, the front is the front. So what we now appreciate is that estrogen receptors are not just in the vagina. We have estrogen receptors in the vulva, which is on everything on the outside. Externally, a lot of women say that they're talking about their vagina. They're really talking about their vulva. The vagina is inside. And we have estrogen receptors in the bladder along the entire urinary tract. And when your estrogen tank is on empty, then we start to see profound changes in all of these structures. Next slide. So if you look, next slide. Next slide, Jessica. Is that working? Okay, outside. So if you look on the outside, which you should be doing, by the way, you are not imagining it if it looks like your labia are disappearing. They may be disappearing. And that nice rosy pink color, that means you've got a nice blood supply at the opening of your vagina and on the vulva, suddenly it gets very pale. And you might even start your urethra poking out a little bit. But then we go to the inside. Now, you can't see inside your vagina, but I can, and so can your gynecologist. And we don't have to talk to you. It's real obvious to us that we see that you have a loss of the structure. Those nice accordion-like folds that allow the vagina to expand, gone. Lubrication, gone. Elasticity, gone. So as a result of all of these changes, then you have the symptoms. So genitourinary syndrome of menopause is really two things. It's what are the physical changes that occur, and then what are the symptoms that you experience, both genital and
urinary. It's not just about the vagina. So this is what we're going to talk about. We are going to go through these symptoms. We're going to talk about the fact that you have pain with sexual activity, not just intercourse, but any kind of sexual activity. Orgasm, like, forget it. It's just not happening, but this is all solvable. The itching, the burning, and then the urinary symptoms, the fact that you got that gotta go feeling all the time. You put the key in the door and there's no way you're going to get your pants down by the time you get to the bathroom before it's out. So, recurrent urinary tract infections. All of this is part of GSM. So I'm now going to introduce this rock star panel because we are going to go there. We're going to talk about this. And you already know Cheryl Kingsburg, Dr. Kingsburg. But one thing you may not know about Dr. Kingsburg is that what she really wanted to be was not a psychologist. She wanted to be a comedian. So as a backup, she went into the psychology of, sex with lots of opportunity to be very funny. So we appreciate that. And then I'm going to skip over to Dr. Rachel Rubin, who is already a urologist, sexual medicine urologist, who is very famous, but became more famous last month when the New York Times did an article on the clitoris. So now we have crowned her the queen of clitoris. And she even has a lovely clitoris necklace, which maybe she'll show you, which I covet. And then our third panelist is Dr. Maria Ucoco, who is also did I just say that wrong?
Uloco.
Uvocos, I'm sorry.
Uloco, like you're crazy in Spanish.
Exactly, I'm sorry. And I love this panel already. And also a urologist, sexual medicine expert, who, the fun fact I learned is that you are in the top 0.01% listeners of Beyonce on Spotify.
I am. That 3 years in a row.
And there you have it. So, but okay, what we're going to do to start this off is we're going to start with Dr. Kingsburg, because we are going to be talking a lot about these physical changes, but we can't ignore that there's a psychological component as well. So can you just start by talking about how that all interacts?
Sure. Well, treatment number one, changing your position. So here I have changed my position. When we think about sexual response and sexual function, healthy and dysfunctional, you really, and we talked about it before, but in sex in particular, you need to think about it from a biopsychosocial perspective. There are many things in physical health that will contribute to sexual dysfunction. So your general physical health, whether you have diabetes, whether you're overweight, whether you have thyroid problems. Also, neurotransmitter dysfunction will impact your sexual function, and certainly hormones will affect sexual function. But beyond that, you have psychological factors. Depression, we talked about that before. There is a bidirectionality between depression and sexual function, particularly desire, or anxiety. Think about performance anxiety. Males, people with penises, tend to worry about getting and keeping erections. Females worry about reaching orgasm, which Dr. Stryker will talk about. So the more you worry, am I going to get there? Am I going to reach an orgasm? You're done, because now you're distracted. Sociocultural factors, religious, prohibitive cultural backgrounds that say sex is dirty, girls aren't, or women aren't supposed to be sexual, absolutely tremendously negates sexual function in women. And finally, the interpersonal component is huge. The quality of the relationship, if she has one that somebody is in, will make a difference in her sexual function. You could have all the biologic drive in the world, but if you don't like your partner, you're not going to want to sleep with them. And so you need to think about that when you are approaching your clinician or thinking, what's the matter with my sexual function? Sometimes it's 1, 2, 3, or all 4.
So, Dr. Rubin, I'm going to throw this over to you now, because we're going to be circling back to this a lot as we go forward. But I would like you to just explain the nitty-gritty of why does penetrative sex hurt, whether it's a penis or a toy, but why does it start to hurt in a woman who is whose estrogen tank is on empty?
Okay, so this is, do y'all hear me? Apparently I've had major mic malfunctions. No, you can't hear me?
Hold it the way I...
All right, sorry guys. Now do you hear me? Yeah. All right, major mic malfunctions. Similar to sexual dysfunction, right? When things don't work when you want them to, and no matter how much breathing and yoga you do, if the machinery is not working, it's not going to work.
So this is really important, right? Biology is really important when we're talking about sexual health. And I love that Dr. Kingsburg is here. Look at this incredible panel. You've got a gynecologist, 2 urologists, and a clinical psychologist who, this is all important for sex. It's not one or the other. It's a team approach. And the physical therapist in the room, hello, we love you. So biology is really important here. And so who has ever, this is a weird analogy, but I'm going to do it anyway. Who here has ever changed the diaper of a baby girl? You can come to my house if you want to. So it's really important. Babies, okay, do not have hormones in their bodies. They have teeny tiny vulvas. They have no labia minora. They pee their diapers all the time, right? And they're constantly saying, "Ooh, mom, it itches. Mom, I don't, it doesn't feel good." We put diaper cream all over it because it looks painful to us, right? That's why diaper cream was invented. So we didn't have to look at how, uncomfortable it looks. That is no hormones. Then puberty happens. The teenagers, they start getting mean to you and they start getting sassy. Who has teenagers, right? Yeah, I'm sorry. But their bodies change and transform. They grow labia minora. The tampons can start to go in, the menstrual cups, which all the teens love, right? They start to go in. So the body literally morphs and changes. And it's not just an estrogen story, but it's a testosterone story too, which we're going to talk about. And so what happens in perimenopause and menopause is now all those receptors, which were so full of hormones and getting all the hormones, like getting a plant, getting enough water, right? So full and blossomed, now start to lose all of that water, right? And you no longer have it. So it could happen before you stop getting periods. It can happen later, but over time, without hormones, the bladder is affected, the urethra, the vagina, the vulva, the clitoris, all of the parts, right, are affected. So it is not just hot flashes and night sweats. And without hormones, it's not just vaginal dryness either. It's urinary frequency and urgency, just like Dr. Stryker just said. And so sex can become painful. Orgasm can become muted. It can take longer. The things that worked 30 years ago ain't working anymore. And it's really hard to say to your partner, honey, a little to the left. Who has a hard time saying, did you learn how to say that in middle school? I didn't, right? And how do you have that conversation? So this is really important because we minimize the term vaginal dryness. By telling women it's just a little vaginal dryness, put some lube on it, we're actually killing women because women are dying of urinary tract infections. They're getting divorced. They're having a difficulty communicating with their partners. This is a huge problem that we're really not capturing by just saying, oh, it's a little vaginal dryness.
And okay, when does this happen though? Because everyone thinks that this is going to happen the same time as the hot flashes. So Dr. Loco, talk about when does this vaginal dryness and this painful sex hit?
So the vaginal dryness and the painful sex can hit at any point in time, actually. So, because all of this is related to hormones. So anything that's going to essentially affect your hormone status can essentially affect the health of your vulva. So I always tell people that this is such an awful analogy and I apologize, but your vulva is a garden. And so without hormones, you cannot water that garden. And my patients groan and but it actually makes sense. So if you don't have the appropriate hormones, and it's more than estrogen, it's also testosterone, there's progesterone as well, to keep that garden healthy, that's when this is going to happen. So perimenopause, some medications can also cause this. Anything that essentially affects your hormone status can affect your vulva, which then, if you don't have a healthy vulva, you cannot have a healthy bladder, and you cannot also have a healthy pelvic floor.
But I think also go ahead. Okay, go.
Here's the problem with midlife is that hot flashes and night sweats, every single woman knows is about menopause, but they don't know that GSM is related to menopause. And what tends to happen is that it occurs a little bit later on. And so they're like, oh, I'm done with menopause, but yet they're having these symptoms that they don't know are related to menopause. So they're not bringing it up to their menopause practitioner or their primary care. They think it's just a natural part of aging and I'm supposed to learn to suffer and live with it, when we absolutely, you guys absolutely can treat it. So it happens usually a little bit later on. And while night sweats and hot flashes sometimes will eventually go away, GSM is chronic and progressive and will only get worse, may even kill you, but will only get worse with time if you don't treat it.
If it's not treated. When you're done with menopause, when you die. There's no such thing as I'm done with menopause. You will never have the benefit of estrogen again without treatment until you die. And that's the reality. And it's so important because a lot of people think it's a normal part of aging. So let's talk about, we're very solution oriented here. So Dr. Loco, start off by just quickly reviewing through the over-the-counter treatments, because we know you are not going to your doctor because they're clueless. We've already established that. So you are going to go and find what you can to grease the skids. So what's out there?
Yeah, so the over-the-counter options are essentially, we're not getting down to the root issue, but for some people, it's a great option for them. So things like topical moisturizers, lubricants are also a great option for people. Things like coconut oil, olive oil, you know, things that are essentially not caustic to the skin, but can provide the lubrication and help mitigate the symptoms of the vaginal dryness. So that's typically where people will start with over-the-counter.
Do we all agree that coconut oil and olive oil are good lubricants?
Yes, you have to be careful with condoms, though.
Not condom compatible. They can cause infections, and I quite frankly don't think they're slippery enough. And I don't really think people want to smell and taste like an olive oil. I'm just kind of throwing that out there.
Can we differentiate
Lubricants and moisturizer,
moisturizer?
they're not the same thing. That was my next question. Go
So
for it.
first of all, lubricants are a multi-million-dollar industry for a good reason, because millions of women use them. So please don't feel like there's something wrong with you. And tons of premenopausal women are using lubricants. For a postmenopausal woman, tough word, osmolality, you really need to look at what's the ingredients in your lubricant to make sure it's not drying, right? And so that's important. So a lubricant you use during sexual activity, it is short acting. You can use a water-based, please, water-based, or a silicone-based. Think about what the ingredients are if you're sensitive. A moisturizer is just like you would use for your face or your legs for dry skin. It will help provide moisture. It will not treat the underlying condition, which you talked about. That will not treat that, but it will help with moisturizing. Use that 2 or 3 times a week, not during sex. Lubricants during sex, moisturizers, just as you would moisturize your skin.
Okay, so once you have decided that that's not going to do it for you, you might have to actually bite the bullet and go to your doctor, but we want you to go and ask for a prescription because your doctor may not know what to give you. So, Dr. Loco, why don't you now walk us through what are the categories of prescription options? We won't get into too many details about them right now, but just kind of run through what the options are for, because one of the things I want to make the point that lubricants do not change the tissue. They only make it more slippery. And that's why they're not going to work for everybody. A prescription is going to change the tissue. So what are the prescription options?
Yeah, so prescription options, essentially you can break it down into prescription options that is going to restore estrogen back to the tissues. And there are various options. You can do a cream, you can do a gel, you can do tablets. Then there's also the option of estrogen and testosterone. There is an FDA approved option, and that's typically FDA approved for patients with not only sexual dryness, but also sexual pain. So that is a medication called progesterone. It's a vaginal insert as well. And then there's also selective estrogen receptor modulators. So these are oral medications for people that it's not safe for them, or it's been deemed not safe for them to have a direct estrogen. So that's another option for patients.
Yeah, and just to clarify, the progesterone that you were talking about, that's actually not estrogen and testosterone, it's DHEA, which is the precursor, and then your own vaginal cells make estrogen and testosterone. And as we talked about before, testosterone is not a male hormone, it's a human hormone, and it's very important in the vagina. So Dr. Rubin, so now the woman has gotten her prescription, she's brought it home, and she's read that terrifying label. Can you talk about that, please?
It's so important, right? So not a day goes by where a patient doesn't come back and say, well, I've been given this prescription 3 times, but I'm not going to use it. It says that if I use this, it's going to cause stroke, heart attack, blood clots, dementia. And if I don't use this product with progesterone, it's going to give me endometrial cancer and I'm going to die. Dr. Rubin, you are trying to kill me. Every day, right? So this is actually a big problem. And for any of you listening who work at the FDA, we got to talk, right? We got to talk because this labeling, the box labeling is killing people, right? Women are not using these products because they are afraid. And there is not one documented case really of vaginal estrogen or vaginal hormones doing any of those things. No data. Come at me with the data, people. Show me the papers. They are not there, right? And so here's the problem. The Women's Health Initiative, which was so beautifully explained by that brilliant Yale doctor, it was incredible, that first panel, right? It really screwed a lot of things up. So even the labeling's not even based on the actual data that the WHI came out with. It says with you, right? So that the FDA labeling is for all hormone products, but not all hormones are the same. Estrogen is not the same as progesterone, which is not the same as progestin, which is not the same as testosterone. An oral birth control pill is not the same as a patch, which is not. So we have to understand there's a lot of gray here. So vaginal hormones, local hormones that are treating GSM, genitourinary syndrome of menopause, are pretty much safe for everybody. Again, you heard it earlier. The only patient where I will pick up the phone and have a conversation with an oncologist is if they're on an aromatase inhibitor, and I'm still going to push for it because this is not a little vaginal dryness. This is recurrent urinary tract infections, which can kill my patients, right? And so it's very infuriating as a urologist because we see the changes, we see the pain, the sexual dysfunction, the urinary frequency, urgency, leakage, these really significant symptoms. So we have to educate, and I do a lot of teaching and yelling. Dr. Luca and I do a lot of screaming and yelling about how the box we must educate patients before they leave our office of this box is based on if you took a different pill completely by mouth, and even that's probably much safer than what this box says. So we have to tell them that the labeling is wrong, and we get on our soapboxes and we talk politics and we talk the FDA. I'm in DC, so we talk politics all day, and we get them to understand that this is wrong, right? It would be like a condom label saying condoms cause blood clots. Right? Because birth control pills can cause blood clots, and it's both contraception, so condom labels should say cause blood clots. Well, that's ridiculous, similar to how ridiculous it is that vaginal hormones have that labeling. So for anyone
don't
who
read
has
the label, and just to put a button on this conversation, please. We have 4 experts on the stage. Raise your hand if you give a local vaginal estrogen to a patient with breast cancer.
Oh, all day.
And there you have it.
But can I put this in context? Vaginal estrogens, when you think about, Dr. Minkin said you might get a little teeny bit of systemic absorption. The amount of systemic absorption of 1 year's use of a vaginal estrogen is the equivalent to about 2 birth control pills, right?
Total.
So total.
Maximum.
1
For the
year.
whole year. Maximum.
1 year, 2 pills.
And not to mention, women who carry extra weight make estrogen in their fat, and they carry more estrogen on them than they could possibly put in their vagina. So
just again, numbers I think are super helpful here, right? When you're in menopause, your estrogen levels are 0. When you're on vaginal hormone products, guess what your estrogen levels are? 0. It stays 0. When we give a woman estrogen, like systemic estrogen, we're looking for your estrogen between like 25 and maybe 60. A man's estrogen is 25. Right? A man's estrogen is 25. When I was pregnant, my estrogen was probably 3,000, right? And so we're not running around to pregnant people saying, oh, we got to get this baby out because you're going to get breast cancer, right? Like it doesn't happen. Do women get breast cancer? Of course, it's horrible, right? But the idea that your estrogen level that stays 0 with vaginal hormones, what are we afraid? Like, what is the fear? Like, that's my problem. There's nothing to fear.
Okay, we have to move on from painful sex, otherwise we'll never get to orgasm, and I know you all want to come to work, so. But one last thing, I want to make the point, and the panel wants to make the point, that you should never have sex. 0 sex is acceptable. And there are cases in which you are having an adequate estrogen, you're using your estrogen, you're doing everything right, you've got your lubricant, and you're still having pain. And so one of you please jump in and talk about the role of the pelvic floor, the pelvic floor muscles, where they come in with all this.
Okay, so pelvic floor physical therapists are angels on earth. And I will go to my grave saying that. So I'm an athlete, and when I think about the body, I think about like how can we physiologically make our body better, and so hormones play a big role in that. And if we think about the pelvic floor, it's literally a girdle. Like it's a girdle made of muscle. And so if we kind of again, this is where biopsychosocial comes into play. If you're someone that has had painful sex, there comes the secondary fear that happens of guarding. So I always use the analogy of if I'm going to throw a punch at you, what is the first thing you're going to do? You're going to want to, tense up and block it. And that's what happens essentially with penetrative sex. If you're having continuous pain with penetrative sex, your pelvic floor muscles are oftentimes going to tense up without you knowing, and that's actually the terminology of vaginismus. Everyone talks about vaginismus, but it's actually the tensing up of the muscles, that psychological connection between those two.
That is the anxiety
Yep,
response
exactly.
to the experience or anticipation of pain.
And so I think if we just kind of think about just how the American culture, and we're a very sedentary culture, you know, everyone needs a pelvic physical floor therapist, no matter what. If you have a pelvis, you should have a pelvic floor physical therapist, because we really don't know. There's a lot of mind-body disconnection. And so just in general, at baseline, I think everyone needs a pelvic floor physical therapist. But then now you have dysfunction on top of that. And so those are people that are going to help reset the muscle. So we can help treat your tissues. Dr. Kingsford can help with the psychological component, but we need someone to help with the muscular component. And that resetting the psychological muscle response of, okay, I'm going to have penetrative sex. I'm going to relax. I'm going to breathe. I'm going to strengthen my core. I'm going to use that breathing exercises, the strengthening core exercises, the flexibility, all of these things. It's a really amazing tool that we have, and we are so thankful for our pelvic floor physical therapist.
It's really important for everyone to know this is not just a Kegel exercise. In fact, a lot of times you want to do the reverse thing of Kegel exercises. How can I strengthen so I don't leak? So don't, and by the way, research shows that if everyone do a Kegel exercise right now, 80% of you suck at it, right? So excuse my language, but right, like no one taught you. So actually having a coach teach you you're all using your butt muscles and you're squeezing all these things. So you're doing it wrong. And so what a physical therapist does is customizes the treatment for you of like, wait a minute, this muscle's too tight. This muscle's too weak. This muscle's too strong. Like, how can we actually get your body functioning? And the idea that you can just, do it yourself or read a Google, article about it, and all of a sudden you know what you're doing. Hire a coach. That's where it becomes extremely helpful. And there are a lot of amazing websites that you can find a pelvic floor physical therapist on. The American Physical Therapy Association has a great website, and again, you can't just see anyone, right? You can't see a knee guy who's going to help you with your pelvic floor. You have to see, just like menopause and sexual medicine, you have to see a specialist or someone who has said, I care about this and this is what I do.
All right, so we've established pelvic floor PT are magicians. We have to move on. We're never gonna. Okay.
You have to give a
Just so you know, we're all
moment.
friends.
You have to give a moment to cognitive behavior therapy. Somebody asked what it is. So for vaginismus, that is, you could treat all the pelvic floor muscles and you can give vaginal estrogens, but once that anticipation of pain is there, and women need to know that, it will not work until you have done some cognitive behavior therapy, gradual exposure, teaching your body you can be trusted again, because it lost trust in you, and the vagina takes over and says she's not so bright. She keeps trying to put something in that's going to hurt. So we will protect her from herself and tighten up and prevent. And so there is cognitive behavior therapy to gradually expose to allow for wanted penetration, whether that's a tampon when you're a kid or a pelvic exam or penetration for sexual activity. Okay, now
Thank you. Okay. Don't panic when the penis enters the room is what you have to tell your vagina, right? The penis, whatever. Okay, so let's move on to low arousal and desire, and I'm going to let you have the floor again, even though I'm concerned that, it'll keep going. No, I'm kidding.
Okay.
All right, so Dr. Kingsburg, let's talk about the two kinds of issues that are going to impact desire.
Okay, so when we think about sexual problems for women, think about it as 4 categories. Problems with desire, which is wanting to be sexual. That is wanting the anticipation, sort of your appetite. There is arousal, which is the body's ability to feel sexual pleasure, genital arousal, which you need hormones for. So lubrication, blood flow to the urogenital tract. Then there's orgasm, which you're going to talk about. I won't. And I'll leave you waiting for that. And then pain with sexual activity. So desire is the wanting and arousal is the genital response. It isn't always in this linear progression. So for many women, they will have what we call spontaneous desire. How often, and I won't ask, but how often does your body signal that it feels a little horny, that you would have a thought about sex, whether or not you act on it? That is your biologic drive. But many women will have what we call responsive desire. They don't really have as much biologic drive as they may even want. But once they get started, then it triggers a response. Then they're like, oh yeah, sex. This feels great. Why don't we do this more often? That's a wanted response, which, by the way, happens much more often in long-term relationships. You know, we always challenge, is it the age of the person or is it the age of the relationship? It is the age of the relationship that tends to cause that kind of boredom and lack of interest, because, you know, that lover that you couldn't wait to see when you were in a new relationship is now the person you've lived with for 20 years, and that's, you know, a little boring. So it's validating to know there's nothing wrong with your relationship. You need to spice that up and put a little bit of romance and passion in. And so that would be more the responsive desire. Somebody was talking about, we were talking about exercise before.
Yeah.
So the analogy I use with women is how I feel about exercise to the athlete sitting next to me. I have no biologic urge to work out. None whatsoever. If I waited for my own drive to work out, I would never work out a day in my life. So I don't rely on that. I know better. I show up at the gym, I put my workout clothes on, I get on the treadmill, and only when my heart rate's up, I've worked up a little sweat, then the smile will come on and I'll say, oh, this feels great. Why was I so hesitant? I'm going to come to the gym tomorrow. And then tomorrow will come and So for many women, it is validating to know if once they're there, they can enjoy it, that may not be a sexual problem. But for many women who used to want and now have lost that, what I will say is women want to want. That is the problem with desire. They've lost that wanting to want. And that is spontaneous desire versus responsive. Did I take too long?
No, there was not. But I think you made such an important point about the SSRIs, because so many women are more likely to take an SSRI than a man, particularly midlife, because they're depressed and they're anxious, and instead of their doctor treating their menopause, they put them on an antidepressant, which then kills their libido, which is the #1 sexual complaint. So, Dr. Loco, could you talk about a strategy for a woman who's taking an SSRI and has found that she's lost her libido? What options does that woman have?
Yeah, so they have several options. So one option is seeing if they can switch SSRIs. There are actually medications and there are newer SSRIs that have less sexual side effects. So just informing the patient is always really the biggest thing. Informing and validating people is like 50% of the job. And then just making them understand that like, this is a normal part. There's so much stress when people come to my office of I'm abnormal or there's something wrong with me. And I'm like, well, in theory, this is an issue, but there's nothing wrong with you. And these are the reasons why it isn't. And so just again, validating and then letting them know that there are different treatment options that are different SSRIs that are better options that don't necessarily have as much sexual side effects. And then cognitive behavioral therapy, you know, that's a biopsychosocial model. Really, like you cannot treat sexual health by just one. There's no one cure fix. And so also talking to them about that. And then what other options, what do you think of, Dr. Rubin?
I agree with everything. And then the idea that there are biological things to help boost sexual function. So if antidepressants can cause sexual side effects, and anyone who's ever taken an antidepressant knows that there are sexual side effects, including low libido and delayed orgasm, right? And so if there's a medicine that can hurt your sexual health, could there be a medicine that could boost your sexual function? It makes perfect sense. And we have options, right? So again, it's often synergy, right? If it's a crappy relationship, there's no pill that's going to make it better. But it's all, you know, I see that woman who comes in who says, geez, Dr. Rubin, I love my partner. My life is like pretty good. I'm really happy. I just want to want, right? I'm on this stable dose of an antidepressant. I'm not depressed, but I want to want. And so that woman has both hormonal and non-hormonal options that she can choose from of what she wants to maybe try. Has about a 60% chance of working for her.
Before I want to could you please just say what there are two FDA-approved options for premenopausal women, so talk about those two first.
Okay, so, testosterone, which we talked about earlier, right? It's not an FDA-approved option for women, but it is in Australia, okay? So we know that there's a lot of evidence behind testosterone and low libido. And we have two FDA-approved options that are approved for low libido, but not in postmenopausal women. They both work great in postmenopausal postmenopausal women, because a 49-year-old's brain and a 53-year-old's brain, not that different, people, right? And so if you can boost dopamine in a woman's brain, you can improve libido. Doctors have been using bupropion and Wellbutrin for years for this reason. So the two FDA-approved options, one is called Addy, okay? It is a pill you take every night at bedtime. Takes about 2 to 3 months to boost dopamine in your brain, but has about a 60% chance of improving your libido, arousal, orgasm, and satisfaction. So it's not just a libido drug, it's a sex drug. And it works. It actually helps with sleep issues surrounding perimenopause and menopause. And the other one is called Vyleesi, which is an auto-injector that you use about an hour before you want to want. So some people take a hit of dopamine in the form of a glass of wine. Some people take a hit of dopamine in the form of vacation sex. Other people take FDA-approved hits of dopamine. And so again, there are, these medicines actually have been studied in randomized placebo-controlled large trials. And when you do a sex trial, by the way, if you want to get into sex research, it's actually quite challenging, because if I give you a sugar pill and tell you it's a sex pill, guess what? You have great sex. Right? Like the placebo response is very strong. And so these are options. That Addy pill is approved in Canada for postmenopausal women. So I always tell my patients, if it's good enough for Justin Trudeau's people, it's good enough for you. And again, you can have access to these medications. They're just not often very well covered by insurance, because if you know, insurance is going to do anything they can to deny you any kind of medication, even for blood pressure, let alone for your sex drugs, right? It's the reality.
Yeah. But I just also want to throw in there, you have to get rid of the pain first. If you have any pain, forget treating libido. So, Dr. Loco, we mentioned testosterone. Could you briefly talk about the use of testosterone off-label in postmenopause women specifically to boost libido?
Yes. So I love testosterone. I am also a researcher, and I think there's just so much in sexual health, so testosterone, let's talk about it. So everyone, when I talk to them about testosterone, they're always like, oh my God, but that's a male hormone. And so I say, hormones, like we've talked about, are not binary. Everyone produces hormones. And actually, if we look at if we actually quantified how much testosterone is versus estrogen, you're making about 1,000 times more testosterone than you are estrogen. Testosterone's in micrograms per deciliter, and then estrogen picograms, and that's just an order of magnitude. Testosterone are making way more of it. And then if we actually, yes, some of that is then converted into estrogen. Well, this is where the research, I do a lot of research because of advocacy. Research is advocacy in my mind. There's still so much question regarding what the role of testosterone is, because no one has looked at that, really spent a lot of time looking at that, because we've always just been like, estrogen is for women, testosterone is for men. But I digress. So when we actually think about where we are in testosterone and what we know so far, is that testosterone, there is no FDA approved option for it, but there are several guidelines regarding testosterone use in postmenopausal women for the indication of low libido. So typically what we would recommend doing is a transdermal option. So let's talk about capitalism and hormone and in the space of menopause. So because there is there's no set clinical guidelines for each practitioner. We're not learning these things in medical school. There are set guidelines nationally, but we are not learning these guidelines in medical school. So then patients aren't getting at their care, versus these direct-to-consumer people are able to then go directly to the patients. And then give them good information or bad information. And so I think there's a lot of information regarding BioT and pellets and all of these things. And I'm a big believer that testosterone is a very vital hormone, but there is at this point in time no evidence on how these pellets, these BioTs, all of these other options that aren't transdermal are safe and effective for patients. And so that's why we always kind of caution, we caution it at this point in time. But as a researcher, I do love that we are pushing the envelope in terms of research and asking these questions. And that is where we're going to see. But for right now, what we do know is that transdermal options for postmenopausal women or postmenopausal people with low libido is a great option. And the hard part, again, is access and finding people that feel comfortable.
And I think all of us are comfortable prescribing. I know we're all comfortable with testosterone, but I do want to mention again with the pellets, extreme caution that it is associated with an increased risk of uterine cancer and other complications. So just be careful out there.
Yeah.
And Dr. Kingsbury, I want you to talk a little bit about, the first panel talked a lot about hormone therapy, of course, but they didn't really talk about the impact of hormone therapy on libido. So could you address that?
Well, estrogen and progestin will certainly help with vaginal symptoms, although systemic hormones are not always enough, by the way. So please pay attention. If you still have genital symptoms, even though you're on systemic hormones, yeah, that's why urogenital. Urogenital.
We do have 2 urologists up here, Dr. Kingsbury. I have to be
so urogenital.
Never forget the bladder.
Please don't think that that's all in your head. You probably need to be on local hormone therapy as well. So that's number one. It will not typically help with drive, with sexual interest, except for taking away pain. It is testosterone.
And letting you sleep, which also helps.
Absolutely. That is very true. So if you're not sleeping well, your sexual desire is probably going to be low. So thank you for that. But testosterone is the one hormone that has been shown to be effective for treating low sexual desire. And, you know, you talk about the politics of this. Those of you who remember Procter & Gamble had a testosterone patch that was trying to get approved in the US, but it got completely decimated in an advisory commission when they wanted a women's health initiative level safety trial for testosterone in women because they were so afraid.
Right. They didn't find anything bad. They just wanted,
they wanted
more and more.
So it did not, it got approved in the UK for postmenopausal, surgically postmenopausal women, and it has never come back. Nobody
And it
has
never
been able
will.
to get it approved.
If people want to get up in arms, so as a urologist, Dr. Rubin and I treat all genders, and so looking at that research of they wanted more safety, they wanted more. I am currently enrolled in a clinical trial. What we know about testosterone in men is it's contraindicated or not. We don't want to give it to men that have had a known heart attack because we're concerned that it could potentially cause more heart disease. But there is this is why it's so fascinating to be on the precipice of all genders. We take care of all genders and see completely the differences in care and the access to care. I am currently in a clinical trial where we are giving men with known heart attacks testosterone. You could never do the same trial with women and estrogen. You know, there's always so many more barriers, always so many more to getting them the care and the access and the degree of quality of life versus, you know, oftentimes I have to tie a lot of my grants, a lot of the stuff that I do to my male patients and saying like, I'm currently one for female sexual dysfunction and men with erectile dysfunction. And like, that's how I get my money. That's how I get my funding. That's how I get things pushed forward. But that's, you know, that's a little ridiculous. And so really always kind of questioning like, why am I having a hard time? So politics, advocacy, research matters.
Research matters, which brings me to the next topic, which is cannabis. How many of you out there have just thought, okay, little cannabis to help with the libido, to help with all this stuff? So roughly 1 out of 4 postmenopause women are using cannabis for relief of one, if not more than one, menopause symptoms. And this is something that I'm studying. We have zero data when it comes to cannabis and libido. And in fact, any publications out there about libido and cannabis are in like 20-year-olds who have no problem with their libido, but they say it makes it better. So there's not a lot to say about it other than we know it's being used. You do have to be careful postmenopausally. Postmenopause women do metabolize cannabis differently, and that's another topic for another day. But I know you're out there using it, and you're quite frankly better off going with some of the things that are more studied and we know something about. All right, I'm watching the time. We're going to talk about orgasm a little bit. Let me just say that the reason why, there's a very specific biologic reason why postmenopause women have such difficulty having an orgasm. And it is simply that you need to have intact, sensitive neurons in the clitoris in order to have an orgasm. And between a lack of hormones, aging, smoking, and in many cases, medical illnesses such as diabetes or vascular disease, those nerve endings just become dead. So you are not imagining it. It's blood flow, and it's not keeping those nerve endings healthy. That's why it is so difficult to reach orgasm, or impossible for some women to reach orgasm postmenopausally. So, so what do we do about that?
So Dr. Luco and I both treat men, and we treat erectile dysfunction. 50% of men who are 50 have erectile dysfunction, 60% of 60-year-olds. The penis needs three things to be healthy: healthy muscles, healthy nerves, and healthy arteries. The clitoris and the penis are exactly the same thing. They are exactly the same thing, made up of the same smooth muscle tissues, the same nerve endings, the same erectile tissues, and they work exactly the same way. It's just that the clitoris is all inside the body, right? In fact, you're all sitting, if you have a clitoris, you're sitting on it right now, your butt bones, it goes all the way down to your butt bones. If you have a penis, you are also sitting on your penis. All of you on your Peloton seats, you're crushing your genitals, right? I have one too, but you're sitting on your penis, you're sitting on your clitoris. So you need three things: healthy muscles, healthy nerves, and healthy arteries. And so the reason why vibration works so well for all genitals, by the way, everybody should be getting devices, and sex tech is incredible now compared to many years ago, right? Where you had the newspapers on the windows, and you had to like create, you can go on Amazon and get a very high-end device. But the reason is the clitoris is mostly internal. And so how can you activate that erectile tissue is often through some kind of a vibration. So again, hormones, muscles, and nerves. You could take hormones, and the clitoris responds very much to testosterone, and certainly estrogen, we know, can help with vaginal hormones. Vaginal estrogen can help with orgasm. Devices, good cardiovascular, right? Exercise is helpful. Viagra and Cialis works for penises. It works for clitorises too. It's just that it is not, it's been studied. It works fine to increase the erectile function of the clitoris, but most women are bothered by their desire, the dopamine in the brain. And so you have to treat synergistically. I rarely just give a woman a Viagra prescription, though I do give the prescription out, but it's often in kind of like, in conjunction with other therapies that we're doing. Yeah. And I got to give a plug for sex therapy. Like, nobody can't get better at sex, y'all. We can all get better at sex, right? You just got to work at it a little bit. And communication, y'all are so successful in your jobs because you meet about it, you talk about it, you plan for it. Like, why wouldn't you invest in getting better at sex? It sounds like it's not that hard. It's not that difficult.
Okay, well, this is all well and good, but let's just start by saying that you need to start with the vibrator. And no, but there's a reason why. There's a biologic reason why, and this is it. I talked about healthy nerve endings. There's lots of different kinds of nerve endings. There's thick nerves, there's skinny little nerves. All the nerves in the clitoris are really, really small. It turns out that the nerve types that respond to vibration are the largest nerves in the clitoris. They're the last to go, women. They're the last to go. So if licking, touching, stroking isn't working for you anymore, vibration will. A vibrator is not a sex toy. It is a sex tool. It is a sex tool. So you start with vibration first. And Dr. Kingsburg is going to tell us what kind of vibrator to buy. And she's also going to tell us how, when you want to bring Bob, that's your battery-operated boyfriend, into the bedroom, how you're going to explain that to the person who's already in bed with you.
So that goes back to sex therapy, and you don't need to spend a fortune. So let me just say, just so it's accessible to all. Thank you to Amazon and goodvibes.com. There are many websites where you're not going to end up with all that spam email. There are sort of female-friendly places. But really, don't spend a fortune, but you have to think about what kind of sensation works for you. Some women really want something that is going to sort of blow on their clitoris directly. Others do not do well with direct clitoral stimulation. So you need a much more sort of diffuse kind of vibration. Some people are going to like something with a rheostat that you can control it's not just vibration, it's what's the intensity and the speed of the vibration. And so you got to learn to see what works for you. And that's why you don't want to invest in a really expensive one at first. Go inexpensive, find what kind of vibration works for you. And then you need to explain to your partner, if you have a partner, that this is important for enhancing sexual health. your partners want to feel desirable and desired. And so if they see you as bored and unsatisfied, they're not happy with that. So if there is something that they can do and be a part of, that they can feel like, wow, look at her response, they're very happy, especially when you say it really isn't you. This is me. And they're willing, yes. And men, people with penises get it that, you said at 50, they're not getting instant erections at the mere sight of their lover anymore. And the partner needs to recognize it's not that they're not attractive anymore, it's that the penis doesn't work that way. I'm talking to two urologists over here, but I hope you can back me up on that.
Yeah, that's right. That works. I also like to say that sex is play, right? And so kind of coming at it from a playful mindset of, well, let's see, and kind of curious of like, what does this setting feel like? What does this vibration setting feel like? And it's literally called a sex toy. Like, have fun with it, and incorporate that into sex, and figuring out and having the communication piece with your partner of like, let's go have fun with this fun new toy.
It's really fun as a doctor, right? Doctors and all clinicians really should be talking to their patients and giving their patients permission to play with these devices and discover these devices, because I actually find biology really helps here. When I'm teaching my male patients about how their penises work, I'm also teaching them how the clitoris works and where it is and why they didn't learn it in middle school either. And again, as urologists, it's really fun because we can take care of any love triangle that comes into our office, right? And so it doesn't matter who you're trying to have, like literally come to my office. Let's talk about what genitals you have, what genitals you want, and how you want them to work. So it's not really binary, and it's not really male or female or even heterosexual for that matter. It's let's talk about what is the biology here and how is it functioning? How is it driving? And do we want it to drive better? And there's nothing wrong with wanting to have more fun, more quality of life. It doesn't have to just be about hot flashes. And I think maybe the box of estrogen says you can only use this if you have hot flashes or night sweats. And we have to change that to sort of really understanding what gender affirming care is. We want people to feel like their best selves, and we want to help them do that through a biopsychosocial approach. And so you really do need to be inclusive. And so again, for Dr. Aluko and I, we see everybody. And that's really fun because we actually see how people are not that different. And we actually use a lot of what we know about one side of the genitals and actually use them to help us with the other side, right? And that becomes really helpful. But when you only teach gynecologists gynecology and you only teach urologists male sexual health, like no one's talking to each other. And that's a big problem. We actually want couples of any kind to talk to each other in the bedroom and to know, oh, this is, I love when couples come watch me do an exam and they're like, oh, that's where that is? Oh, it hurts there? Wow, I thought I was just unattractive now. No, like it's like a sunburn on the, on the parts. It becomes, biology actually helps to make this less scary and less emotional and less about feelings and more about physiology.
Okay, education is really important from you, from me. Here's one thing that a lot of women always feel uncomfortable about. Women will come in, they'll say, let's say husband tells me there's something wrong with me because I can't reach orgasm with his wonderful thrusting. And so first I have to sit her down and explain delusion disorder. Thank you to the psychiatrist. And then we have to explain that the majority of women, females, people with a clitoris are not reliably orgasmic with penetration alone. And they feel like, oh my, really? I'm not broken? And that is so empowering to women to say, you need to figure out what works for you, which is why getting a vibrator that penetrates may be nice for some women who are lucky enough to have that sensation and can reach orgasm with penetration. But they need to, if you don't, you need to find more external vibration, which is usually going to be the most effective, especially as we age, based on the nerves.
I want to circle back a little bit because we talked about SSRIs and libido, but it's also the issue with having orgasm issues on an SSRI is very, very common. And in what, about 30% of people, you would say it does go away on its own. But what someone wants to throw out your solution for the patient who is an SSRI who cannot have an orgasm, beyond all the things that you already talked about in terms of decreasing the dose and all of that?
think it is all the things we talked about, right? And you have to tinker and get it right for you. This is where it becomes customized care, and toolboxes are really important, and it's important language, because your orgasm really matters. It's really important. But you may go to your general provider and they don't really have the tools to help you, or the time they're like, lady, I got people with cancer, people having babies now. Like, I don't have time to tinker with your orgasm. But there are providers out there that's what we care about, right? Like, it matters. And if it matters to you, it should matter to your clinician. And so the key is we have to get it right for you. So depending on your mental health history, depending on what medicines you've tried, depending on what's going to work and what you're open to trying. So it may be a device. It may be Viagra or Cialis. It may be changing around your SSRI. It may be adding something like Addy or Vyleesi on top of your SSRI.
But wouldn't you agree, though, that we talked about, that Viagra is not always going to work? But if it does work, isn't the woman, I think, and I want to know if you agree, that it's most likely to work and is the woman who loses her orgasm specifically because of an SSRI?
Well, we do have some data to show that Viagra can work very well in women with SSRI-induced sexual dysfunction. And the answer is, we've got great data to show Cialis helps prevent heart disease and heart attacks in men and all of these things. So I think it should be in the water, to be honest. But, but I think it's understanding how again, it's really erectile dysfunction, right? Orgasmic dysfunction is erectile dysfunction in women often. And so things like Viagra and Cialis and devices can work quite well, just like they can for my male patients.
So we are working on a topical Viagra, sildenafil is the generic, for women with arousal disorders, because now, we always have to use male products because there's nothing FDA approved. There are only two drugs approved for HSDD. No, it's
off-label. And compounding pharmacies will do it.
Right, but we are looking at, and phase 2 trial just completed, we're waiting for the data for a topical sildenafil for women with arousal disorder. And again, we have nothing for orgasmic disorder, nothing FDA approved.
Or just on the clitoris? Because
both.
Okay, because vaginally I could be convinced, but because like rubbing
you rub
Viagra
anything
on
the
the
clitoris
doesn't
long
really
enough, it's
work
gonna
very
help.
well. Like we would have if it actually worked, we would have a male We would have a male product already.
Yeah. All right, okay, you guys are going to be so happy
because
now we are going to move on to the bladder, your favorite organ, right? Yes. Okay, but before we move on, I want to point out that there is Menopause Talk number 3. You will get a full hour of these two experts talking about solutions for recurrent urinary tract infections, urgency, frequency, leaking, a full hour, and really you do the deep dive. We don't have that kind of time now, so I encourage you, but just give a little bit of an overview of quickly, because it's really what we've been talking about, how this is going to affect the bladder. What are we going to? Yeah, I know.
Okay, so a healthy vulva is a healthy bladder, period. That's it. If you do not have a healthy vulva, you cannot have a healthy bladder. So if we look at that diagram here, you can literally see that the opening of the bladder literally sits within the structure called the vestibule. That structure is dependent on hormones. It's all the same tissue. And so again, I'm thinking about optimizing your tissue health. If you do not have a healthy vulva, which includes all of the things, which typically is with hormones, you cannot have a healtty bladder. And so oftentimes there are so many people coming into my office saying they have recurrent UTIs, they have, whether it's true, whether it's not. Because actually I looked at my data, 60% of premenopausal women come into my clinic with recurrent UTIs. It's actually the vulvar condition. It's not the urinary tract. And so there's a lot of misdiagnosis of urinary symptoms that are actually vulvar symptoms. And if your vulva is not healthy, you will constantly think that you have a UTI, whether it's clinically true or you feel the symptoms. That's also a really interesting thing of people come to my office and they're like, I swear, and they're trying to convince me. I'm like, I believe you. It's not they're like, I have a negative culture. I have this, but I have symptoms. And I always tell them, I believe you. It's not your bladder, it's your vulva. And we do the full workup as a urologist, but what I've been finding is that if you do not have a healthy vulva, you cannot have a healthy bladder.
Dr. Rubin, keep it short. 2 sentences.
We just don't teach this to urologists, which is the problem, which is we go, like literally Dr. Luco and I are going door to door to urology programs lecturing for free because we're trying to teach the residents that this is really important. And no one taught us in medical school how to examine a vulva. Nobody. Nobody taught us in urology school how to examine a vulva. So we are literally going door to door to say, here's how to do the exam. Here's why it's important. And so again, this is not just about sex. This is about like health, because that, little old lady in the nursing home is dying of a urinary tract infection, which we could prevent if we were using local vaginal hormones. So just really important that urinary health, like menopause and urinary health, go together hand in hand, and we got to start talking about it.
And let's just talk for a second about the fact that below the waist has become a no-fly zone in the internist's office, and that they're not even looking at your vulva because they say you don't need a PAP. Well, PAP has nothing to do. Have we even mentioned the word PAP test today?
Nope.
No. A PAP has nothing to do with any of this. So, Dr. Loco, talk about, should women from over the age of 50 till death have a vulvar and a vaginal exam?
Yes. 100% yes. So we use the term vaginal atrophy, and we just toss it around in the medical field. And it's essentially like, if we actually think about it, we are permitting a whole organ to become unhealthy. It's just like if they told me if I didn't walk, this leg will shrivel up. It's like, well, you could just walk 10 minutes a day and this leg will stay healthy. We could easily be preventing so much suffering, pain, all of these things if we prioritized vulvar health in our primary care providing clinics, in our gynecology clinics, in our urology clinics. It should be the exact same. I strongly believe that, just like you get a mammogram, just like you get your heart checked, just like you get this, you should be getting your vulva checked, and you should be making sure that your vulvar health is optimized, because without all of those things comes this the sequela, the long list of all of the downstream effects. And also, everyone, look at your vulvas. Go home today and look at your vulvas. So there is such a fascinating thing of every time I examine a patient with a vulva versus my penile patient, they apologize to me, every single one. And I thought that was the strangest thing initially, but now I'm realizing it's internalized shame that we've all been ashamed to look at ourselves. And when you're not looking at yourselves, all of these changes start happening, and you never know. And so I have people come to my office, they look at themselves for the first time, and when the symptoms start happening, and I'm like, this is like decades of changes. The symptoms just started now, but this is decades of changes, and we could have prevented this if you knew this. And so that's why I always encourage people to look at yourselves, and frequently, just like we talk to do testicular exams, look at your vulva every month. And once you start noticing these changes, go see someone.
Yeah, we need to normalize the vulva.
Yeah.
And look at my Instagram at Dr. Strike to see the Great Wall of Vulva. 500 vulvas, that's a whole nother story, but I won't go there now. But okay, so if you think it's hard to find someone who's gonna help you with your hot flashes, try finding someone who's gonna help you have an orgasm, right? So, Dr. Kingsburg, please talk about how you find such a person.
Well, now you can, besides going to NAMS, now you can go to the International Society for the Study of Women's Sexual Health, ISSWSH, ISSWSH.org, and you can find a provider there as well. They are not specified by, whether they're a gynecologist, psychologist, but you can then look at their profile and find somebody there. And that's a nice one. ASECT, AASECT.org, all sex therapists, varying interests and qualifications, but ASECT has also sex therapists, and STAR, it's the Society for Sex Therapy and Research, SSTAR.net. STAR.
We're going to take some of these resources and email it to everyone who attended today. Okay? I won't guarantee it's going to be this week.
I'm disconnected.
Next week?
Okay, we're going to open it up for questions now.
Yes, we're going to open it up for
my
questions.
iPad seems to be disconnected from the internet, so I'm not seeing them.
Okay, so Jessica's going to take out that
poll.
poll. She's going to stop the poll and then put up the questions. And does anyone want to come up here and ask a question?
But we'll take a question in the back, and the woman in the dark. Yes.
Oh, we go here.
Oh,
right here.
all right. Hi, thanks very much, first of all. I only recently discovered where my bladder was because it has never been an issue. All of a sudden, things are feeling wonky. And I didn't know what specialist. So I went to all my usual ones, the GP, the OBGYN and all that stuff. And then I said, well, I probably need a urologist, but a urologist is a male problem doctor, right? And I guess my question is this do you need to introduce a urologist as a matter of course when you hit menopause? And the second question is, you are the first 2 female urologists I've seen. Yay.
Did you hear the question?
Is it a heavily male-dominated profession?
Yes. So we are less than about 10% of practicing urologists. If you want to meet a cool person, obviously, women urologists are cool people. We have to be funny because we're penis doctors, right? We have to be funny. And so we all get along very well, but we're about 10% of practicing urologists are female, but the residency training is 25%. So we are growing in number and getting very, very loud. And so when we get board certified, we are board certified to take care of all genders. We are just get worse training in taking care of women. And so we are actively trying to change that. We do. And the American Urologic Association is incredibly supportive. We have courses, we have trainings, we have core curriculum. And so to your question is, you have to see a doctor who or a provider, clinician, whatever you want to call it, who knows about this stuff. And so there are lots of gynecologists who do urologic stuff. They're called urogynecologists. There are a lot of female urologists who focus on female issues. There's a lot of men urologists who do female urology specifically, so it gets confusing. So the key is getting good referrals, finding someone who cares. And those websites, ISWISH is very helpful to find a clinician who is going to do those things. I hope that's helpful. But we're changing, we're growing. And I wish to one day, right, that all women's health is not just gynecology. It's enough already, right? This is misogynistic that there is one medical field for all of women's conditions, primary care, cardiology, urology, like we all take care of women and we all just need to do a better job. And that's why we're yelling and screaming in the work that we're doing.
The question, is GSM inevitable? The answer is about 70% of women will get GSM. And it is something that can present later, and it will not get better without treatment. But I do want to get to this question, which is so good, about, where was it? About how you put estrogen on. Should the cream only be used around the urethra or in the vagina? Because you talked so much about using estrogen cream, but you didn't really say, where do you put it? How? Be specific.
Yeah. So this is where, again, knowing your anatomy is really important. So I actually, in my clinic, I will examine the patient. There will be either my colposcope, which is like they can actually see themselves on the screen, or there's a mirror depending on where I am. And I actually make them put the medication on their finger and then show me where they're going to put it. Because if you, again, gardening, I don't know why I don't garden, but if you have your gardens over there and you're watering over here, like, of course, you're not going to get any cucumbers or whatever you're growing, right? And so you have to also know where you're putting it. And you want to put it, depending on what you're using, whether it's, you want to put it inside the vagina and the vestibule and coat the vestibule as well. And so.
Can you define vestibule? Because not everybody knows.
Oh, yes. So do we have that picture? So the vestibule it literally means entrance to the temple. And so.
Entry to the temple.
We think about the vagina as the holy temple. The vestibule is all that tissue surrounding it. It's actually a really, really important structure. And it's bladder tissue. It is essentially bladder tissue.
And it doesn't matter how nice the room is if you can't get through the door. I'm just saying.
Exactly. And so it is, you want to essentially spread apart your labia minora and get the medication into the vagina and all around the vestibule, because it's really important.
Properly dosed, because a lot of doctors will tell you, just use a little.
Yes, you do not.
Dab on the urethra. You can dab it all over your urethra, but you need enough. So you need at least 1 gram of the cream. And I like the tablet inserts often to start off with, just because then the ER doctor can prescribe a tablet insert. But if the ER doctor is talking about cream and doses, and women don't often love putting creams in their vagina, so the best therapy is the one that you will use and you will use forever, whether it's a tablet insert or a cream, and you have to use enough so that it helps your symptoms. And it takes 2 to 3 months to work. Okay, you don't get a plant back from being too dried out overnight. You gotta, right? Garden. I love that analogy. You have to give it time, right?
I just wanted to ask a quick follow-up to, I don't know who asked the question, but if you go to see, are all urologists male? trained to deal with women? Or do you have to find a female urologist? That's my question.
Fellowship. These are fellowship trained. This is sexual medicine.
We are a little bit unicorn in the fact that we did a fellowship training in sexual medicine for all genders. So we take care of all genders for sexual health problems. There is one fellowship in the entire country that acknowledges women's sexual health. One. And it does everybody, right? Men and when we both did the same fellowship. That's why we love each other very much. And when we talk so fast, is because we know you are only going to be in our presence briefly unless you follow us on social media, because often you don't get this kind of information. And so we talk really fast because we want to teach you everything we know as quickly as possible. And so our male colleagues and our female colleagues, they learn from us. They come to our lectures if they're interested. But many are not interested in this. And we have to beg. But that's why we have to be funny, because we have to convince people to be interested in this, because it is not, but we do have a core curriculum within urology, which has female sexual medicine topics. And that we know because we wrote the damn thing. And so, but gynecologists do not have the same core curriculum. They do not have places, urologists do actually. So that's actually, again, in the fact that we think our gynecologist is supposed to know everything. It's not fair. They can't know everything about everything, and we should stop expecting them to.
And I think this is also where I like to light a match underneath people. It's that, you know, this is where politics and policy comes into play. So we've been up on the stage saying the beauties of sexual health and how great it is. And then you're going to walk out and realize, holy shit, I can't get anyone. I apologize for swearing. I swear a lot. And so that is the issue. So we look at the research and education. So we look at education. We did not learn how to examine a vulva until we were in fellowship. The urethra is right there. We're doing these crazy vulvar vaginal surgeries, and yet we never learned how to examine a vulva. And then if we look at gynecology training, if we look at primary care training, ER training, like all of these people that are interfacing with the vagina, you are not getting that training in your medical education, which is terrifying. So there's a whole workforce of people that have no idea how to examine, you know, we get taught how to, exactly.
Sexual health will never be important enough, right? There's like heart disease, and there's, you know, babies, and there's like cancer, and all of these things are always going to be more important than your orgasm. But that's why we yell, because your orgasm really matters,
and
right? What? And we talk.
And talk really, yeah. But also,
okay, I want to keep running through questions because I really want to try and get people's questions. So I think this one is a really interesting one. They're talking about, you know, physiologically, why does the changes GSM affect the bladder? And I did talk a little bit about estrogen receptors in the bladder, but I would like someone to address the microbiome and why vulvar washes are idiotic.
Well, so again, and Dr. Stryker did a great job, but it is not just estrogen receptors. There are testosterone receptors in the bladder as well. And so when you play with hormones, there are consequences, sometimes good and sometimes bad. And so different hormones that you bring or lose from your body are going to affect every part of your body. So your skin, hair, and nails are going to change in menopause. Your bladder is going to change. Your muscles that surround your bladder and the muscles of your bladder, because your bladder is just a muscle. Your clitoris is just a muscle, and it needs hormones in order to be healthy. Think, you know, The Rock, right? He's got big muscles because he's got a lot of testosterone. And so hormones are important for muscle health. And so when you don't have them, they get thinner and raw and cracked and irritated, and muscles do not like to be unhealthy. So they get really urgency, right? Your muscle squeezes and you feel, oh my God, I gotta pee. You get frequency, you get urinary tract infections because the microbiome has now changed. Without vaginal hormones, you lose the acidity to fight infection. So you do no longer have an acidic area to fight infection, so your microbiome gets all wonky, so you start getting urinary tract infections and vaginal infections, and hormones can prevent those things, and we're into prevention. We don't want to see you when things are miserable and you're 80 and you've been having infections, you know, every month. It doesn't have to be that bad, and it shouldn't be that bad with good education and safe FDA-approved treatments that can actually fix the problem and not just be a little lubricant or moisturizer to put a barrier on it.
How does oral sex get impacted with all these topical products? What's the order? What goes first? Great question.
All right. Yeah. You just put it on afterwards. High five and then put it on afterwards.
words, really rub it in, but the other answer is men have estrogen and testosterone, right?
They're not going to grow breasts.
Men have an estrogen of 25. You're not going to even blip their estrogen if they touch your vaginal estrogen product. They need estrogen for their bones, for their libidos, for their brains, their skin, hair, and nails too, right? It really needs hormones. So men have estrogen and they have about 10 times more testosterone than the average reproductive woman. So it's, again, numbers matter here because it's very fearful of, I don't want to hurt my partner. And so we talk a lot about numbers with patients because it makes them feel, it makes them feel better. So if a man's tongue touches your vaginal estrogen product, it will not hurt him.
And I think also important to mention the lubricants, of these flavored lubricants. We talked about osmolality. Oh my God, it is poison in the vagina. Do not put these flavored lubricants in your vagina. We're talking osmolalities of 10,000, 15,000. Your vagina osmolalities 300. So that is not the answer. Just osmolality. This is the concentration in the vagina. So this is why so many of the water-based lubricants actually make your vagina drier. They destroy the tissue. And everyone always says, how are we going to know the osmolality? Well, I do have charts and lists in my books and your websites, and you probably do too. But the easy way is, if it doesn't say it on the bottle, I guarantee you it's really high. Like, if it's low, they're going to advertise that. If it's
so the
high,
higher means that
high
you're
is
going to get
bad.
like worse dryness.
Right. You
Higher
want it to be
osmolality, worse
ideally 300-400 max.
We're getting a bunch of questions on laser technologies to the vulva and the vagina. And let's talk about it for a second. There is evidence, some evidence, weak evidence that okay, we can fight about it. There is evidence that if you use a laser on the vagina, you can resurface the tissue, just like in the face. We took it from the dermatology. You can get all these face lasers and things like that. So if you do it to the vulva and the vagina, there's some evidence that you can kind of regenerate tissue, beef it up, make it a little stronger and healthier. And they may be effective for some people, but they're not covered by insurance. They're very expensive. And if your doctor is recommending a laser-based therapy only and not a vaginal hormone product, then it's against everything that we believe in, because the foundation has to be strong. And there is no reason not to use vaginal hormones. Remember, there's no person where it is a true contraindication or not allowed to use hormone, like local hormone therapy. So you can use, if you got all the money in the world and you want to try a cool laser and you don't have a reason, right? But everything can have side effects. So this woman here in the question, right? She developed pelvic floor dysfunction and vaginismus.
In the first place. I have to disagree with you here because we had a little, okay, there is excellent evidence that laser does work in terms of changing tissue, but it has to be in the right candidate, and it also has to be offered in conjunction with everything we've already talked about. But I don't care if we are giving someone estrogen, DHEA, testosterone, whatever, you must treat the pelvic floor as well, because those are the failures. So too often when women come in and they say, I had laser and it didn't work because that wasn't their problem. Their problem was tight pelvic floor muscles. You need an exam by someone who knows what they're doing. And I agree, everyone is a candidate for vaginal estrogen, but unfortunately only 6 to 7% of women are using it. Women with breast cancer are terrified to be in the room with the molecule of estrogen, and we have to offer something.
Again, and it would probably...
You need RCT, randomized controlled trials.
We do have them.
We need larger ones.
They're not huge. So we need more data. We need more
Okay,
data.
so I'm
That
gonna
means more-
stay
okay,
here
we're
on
gonna
this,
get
and I
kicked
want
out.
my microphone on.
Yay to
get my microphone on.
Donna.
So listen, so we have to end, and I am so sorry. And the reason why we started Let's Talk Menopause was to get you guys in front of these guys, right? And we love that there's some disagreements. Of course, there's going to be some disagreements on what to do, right? Of course there are. But we want to present that to you, and I want to ask, who here is mad?
Every day, all day.
Just angry.
Now we're using the Jen gun turtles.
We figured out that this was a problem, right? And of course, it's not rocket, right? But when you ask, like, why have a nonprofit for menopause? There are not many nonprofits for menopause. NAMS is a medical society and a nonprofit that has a different role. There's a woman in the room here, Claire Gill, who started the National Menopause Foundation, and Let's Talk Menopause. Those are the two nonprofits around menopause. We work together, Claire and I, right? We just started. We did this bare bones. I want everyone to know. We did this bare bones. It was me Samara, Jessica, part-time, because we have other jobs. That's it. With a few other people, with Sandrine and with Judy, with other people that helped and volunteered. But this really was a labor of love. And we hope that you really enjoyed it. But the reason why I'm saying this to you is because we actually do need nonprofits around menopause, because you have all of these companies that have started up, and some of them are good. I'm not bashing all of them, but we don't want companies driving policy, driving what women are doing and taking, right? So we heard a lot of things that need to be changed. And there's some women in the room here that we're working with Dr. Kingsburg, with NAMS and other people to get together to work on research, to get more funding for research, to get things in medical schools, to get more in the curriculum, to get the back box label off of it. But we actually need support. So we would love if you could support us. If you love this and you can, please donate, tell your friends, tell your families, because we really actually need the support and infrastructure to be able to do programs like this all over the country, in workplaces, in schools, in hospitals. Let's do more trainings of the doctors. Let's train therapists. I actually am a therapist, and I see people in menopause. Everyone now is coming to me, and I can't take them because I want to do this other work. There's very few therapists trained in menopause. So then they're seeing women in their 40s, and then they don't know what's going on. So there's so many different levels of this that needs to change. So it's not just one thing that needs to change. Anyway, I'm going to go on my soapbox. But you guys were incredible. Let's give it a hand to the panelists. Right? Unbelievable. All of the panelists were absolutely fantastic. Panel 1, panel 2, panel 3, we thank all of them. So fantastic. We want to thank Cure for this amazing event space. And this actually is being recorded, and we will have it for people. And I do promise everyone there was a lot of questions and answers that we did not get to. So Dr. Kingsburg has agreed to be virtually just questions on sex, right? April 20th, it's on your postcard, so register and tell your friends about it. We're also going to, of course, have Dr. Stryker, Dr. Uloko, and Dr. Rubin back on all of our menopause talks, but we want to do more live events. So support us, talk to us, and we'll work with you. I know I'm forgetting somebody. Sign up to go to our website, letstalkmenopause.org. Sign up for our newsletter. Actually, most of you will probably be on our newsletter, and really work with us. We would love to continue to do this events. Thank you so much, everyone.